That's very important.
I think we can start, sir. Yeah, almost like
I think so. I think so. We have 30 in the class now. The other one will join us. I hope you are hearing me.
yes.
Thank you so much. Let me first of all put on my video and welcome the class.
Okay.
Good morning, class.
Good morning, sir.
Well, welcome. We're going to be together for a lengthy period of time. I encourage you to have a cup of water beside you and a bottle. Good morning. You're welcome. I encourage you to have a bottle of water and a cup of water beside you to sip intermittently. I also want to say that intermittently, about 20 minutes or thereabouts, I will be asking us to do some stretches, obeying the law of ergonomics so that we don't perpetually sit in the same place. I know we're going to have a nice session together, and I will be also stopping intermittently in case you have questions. You may please ask me. It's going to be explanatory enough, and you're going to have this slide afterwards. So thank you very much. At this particular point in time, I hide my video so that I will be able to share my slides. Thank you.
Thank you, sir.
Thank you, Dr. Ole. We are welcome. I hope you can see my slides. Can we see my slide?
Very well, sir.
It's okay. Thank you very much. Like it's been said and it's been advertised, and at the point of introduction 2 minutes ago, we are in for a workshop on assessment and physiotherapy management of congestive heart failure. Once again, I welcome us into this big class. I know we are all seated. Please make sure you are comfortable and ensure that you take every bit of this lecture so that at the end of it, you'll be able to boast of 1 or 2 things that you have learned that are going to put to use on the field of play. And that's me standing in front of the class there, the virtual class, with everything about art being pointed to that will be discussed in the course of this workshop. And I intend that at the end of this workshop, through this workshop, I'll be able to lift our knowledge up concerning congestive heart failure, starting from the basics, so that enough foundation will be laid for you to be able to pick every point of this workshop. And these are the lecture synopsis, deliberately painted blue and red to be able to show the picture of what we are discussing together today. Because we are talking about blood, we are talking about heart, we're talking about oxygenated blood, we are talking about deoxygenated blood. You know, the oxygenated blood is typified like in the blue color, and the deoxygenated blood in the blue color, and the oxygenated blood in the red color. So that's explains the reason why the color of these slides are like this. Particular lecture synopsis. We'll be going from the objectives to the cardiovascular system, look at the heart. From there, we'll look at the heart conditions and the disorders, the causes of disorders, the predisposing factor to the disorders. We try to explore the prevalence in different climes and how this can be developed. We look at the different types and the risks. And at that point, we begin to narrow down to a particular lecture today. After we have been able to examine the symptoms and the pathophysiology, we'll get into the diagnostics and the text that will show how diagnosis of this condition can be arrived at, which is very relevant to us. We'll look at the possible complications, how it can be prevented, looking at the different aspects of management, but with particular emphasis on the physiotherapy management of this condition. And from there, all our focus will be on physiotherapy and how we can maximize our exercise prescription in the rehabilitation process of this condition and the possible prognosis expected. And we look at, for way of illustration, we're going to look at some case presentations as is relevant to us in the context of our clinical practice. And then there are some illustrative video clips there that we're going to have for further studies that will explain things to us. If time permits, I will play 1, 2, 3 of them, but we have quite a number of them, 28 of them. So from there, we'll draw down the curtain later in the afternoon, looking at the recommendations, and we move forward. So we start from this moment. The lecture objectives are this. We intend to explore the cardiovascular system and the congestive heart failure connection. We want to look at how they are connected together. Congestive heart failure does not just happen. It doesn't fall from the sky. It's developed from something, from an error that happened in the course of the system of the body. And that will have to be explained that for us to be able to have a good grasp of what congestive heart failure is all about. And we would seek to understand the pathology and the clinical manifestation of congestive heart failure. And from there, we begin to look at how clinical diagnosis can be made with the intention that we'll be able to have a good understanding and be able to identify this and implement this on our field of practice. And then we will also further look at this. There's this circle of admission, readmission circle in our congestive heart failure. From the pattern in which this presentation is going to be made, you get to understand why patients will have to come in for admission, discharge, and readmitted again, and what can be done. We as physiotherapists, how we can come in those instances. And finally, we're going to look at the comprehensive assessment techniques for patients that have cardiovascular, that have congestive heart failure. Still looking at the objectives, we're going to focus specifically on physiotherapy management of heart failure. Again, for the intention for us to have a good understanding, a good grasp of what is actually happening and how we can really key into the management of it, and how we can now go back to a different field, begin to implement this wherever we are doing our practice. Then in doing this, we're going to strategically probe into the scientific world so that we're going to see the rationale behind our evidence-based physiotherapy interventions, very well documented. And from there, we'll begin to look at how we can optimize exercise prescription in the rehabilitation process, bringing to bear the case study discussions and the real-world clinical applications for us to have a grasp of practical clinical illustrations. That's why we're going to do that. And from there, we look at the illustrations. So we move on now. I hope you are seeing my slides. Are you seeing my slides?
Very well, sir.
It's okay. So we start with the cardiovascular system. The cardiovascular system is made up of the heart, the blood vessels, and the blood. It's actually a closed system that performs 3 main functions. It's a transporter, it's a protector, and it's a regulator. So it transports, it protects, and it regulates. What are the things that it transports? It transports the nutrients, it transports oxygen and hormones to cells throughout the body, and it equally helps to remove metabolic waste product, notably the carbon dioxide and the nitrogenous waste. Then the way it protects is by circulation. You know, it carries from one place to the other, and it circulates white blood cells and the antibodies and the complement proteins too that defend the body against foreign organisms. And how it does its regulation is this. It regulates the body temperature. It also regulates the fluid pH and also the water content within the cells too, so that the body homeostasis will be maintained. By homeostasis, we mean the self-regulatory mechanism of the body, which actually is vital to the health and the well-being of every one of us, because the body has to be able to maintain a stable internal environment despite external changes. Then from there, having looked at the function it performs, the transportation, the protection, and the regulation, we look at the heart itself. The heart itself is when you make a fist. I want you to make a fist of your hand. By the time you make the fist of your hand, that shows about the size of the heart. So it's usually looked at as a fixed size organ, which is actually critical to life. It's vital to life. It is of different sizes in individuals, and the average size is usually looked at like 10 pounds and may actually weigh little or more, depending on the condition of the patient, depending on the size of the individual, and depending on the sex. It's been said that it beats 100 times per day. You see that it's an enormous work. And because it's vital to life, it's the sustainer of life. That's why it has to beat as much as that. And it pumps as much as 8 pints of blood throughout the 24/7. It's not the thing it will go on leave or you go on break. It keeps working like that. Cessation is what brings a disorder onto the body that we're going to look at later on in this workshop. When it contracts, it empties the blood. I want you to do like when you are contracting, when you are closing let's say you open your hand and you are bringing your hands together. That shows the picture of it. And as it does that, whatever is its content, it begins to empty it. And when it relaxes, open up your hand again. By the time it relaxes, it fills up blood because the space is created for that to be done. And that is like an average of 60 to 80 times per minute. It's located in the front of the chest and is slightly behind and to the left of the left sternum bone. You can turn the sternum bone in front of your chest, which is about the middle of the chest. It's slightly behind it. And also slightly to the left side of the body, sitting between the right and the left lung. And that explains the reason why the left lung seems to be smaller compared to the right lung, because it has to make way for the heart to be seated. And that's why on the right side, you can have the right apical lobe, middle lobe, and basal lobe. But you don't have that on the left. You have the apical, then you have lingula somewhere there, and then the basal. So the middle lobe is not there on the left-hand side so that a space can be created for heart to be seated. So heart is actually protected by the rib cage. It's well protected, well secured there. Still talking about the heart, it actually contains some muscular sections which are called chambers, which are going to do justice to it, explain it into detail so that we are going to have a good understanding of it. And these muscular structures controls the beating of it and the speed of the heart rate HR. It also helps to maintain the blood pressure and also moves the blood throughout the body in a coordinated manner. It's so coordinated the way it's doing it. You're going to see that. And in the process of it, like I earlier said, it sends oxygen here and there and it removes waste product like carbon dioxide. So the electrical impulses is what makes the heart to beat. Just like when a house is wired, when the current comes, the current can circulate. So heart is like that too. The electrical impulses makes it to beat and it moves the blood throughout these 4 chambers that I talk about, which I'm going to elucidate further in the next subsequent slide. The brain and nervous system, they direct the heart's function. It doesn't work in isolation. It works in synchrony, in synergy with some other system of the body, notably the brain and the nervous system. And many conditions can actually affect its normal functioning. And that talks about the interwoven nature of the body. A structure is seated in one part, it is being affected and controlled by some other part. What happens in the other part has a way of affecting this organ. Heart is not exempted in that particular instance. The synergistic work of the heart, how it works in relation to the other system of the body, is what slide 16 begin to talk about. It works together with the other system of the body. The nervous system on its own, it controls the heart rate by sending signal to the heart to either beat faster or to beat in a slow way. When it beats faster, the body probably is under stress. When it beats slower, the body is under stress, rest, and it's not all that well challenged. Apart from the nervous system, we have the endocrine system too, sending hormones which signal the blood vessel to either constrict or relax. Don't forget the picture I painted earlier. When I say that bring your 2 hands together, you see that it is contracting, then it is sending out the blood. When you relax, open up your hand, it is relaxing. So the hormone system of the body provides signaling to that effect. And that, of course, affects the blood pressure And then the thyroid gland actually sends signals to the heart to beat faster and slower. And that explains the challenge that could happen when there's a disease condition affecting the thyroid gland. We look at we take the blood pressure of our patient regularly. That is, vitals is something that we do at every point on desk before we go ahead in the management of our patient. We have the systolic blood pressure, we have the diastolic blood pressure. So that's what I want to discuss now. And the diastolic part of it is when the ventricle relax and fill the blood. That is what brings the diastole in. And in the process of it, it empties all the blood into the ventricles. The systolic is on its own, is when the ventricles now contract and then it pumps out the blood. So let's speak it again. Diastolic has to do with ventricle relaxing. Systolic has to do with ventricle contracting. You cannot miss it. Diastolic means the ventricle is relaxing and is filling with blood as the atria, and that process atria will be contracting. You see the intraconnectivity very soon. But when it comes to systole, the ventricles is contracting, and the process of its contraction is to be able to bring out the blood. So the diastole process leads to give you the diastolic pressure. The systolic process gives you the systolic pressure. So we now see that systolic pressure shows that how much pressure the blood creates against the arterial wall during the systole process, that during the contraction. While the diastolic process shows how much pressure is in the artery during that relaxation phase of the ventricle. So you pick that as you take the every time you take the blood pressure of your patient, of your client, your mind begin to flow along this line that it has to do with ventricle either contracting in the instance of the systole, either relaxing in the instance of diastole, and each of these is very significant. The functions of the heart again is actually in a coordinated fashion of the heart chambers. The valves, the blood vessels, they contribute in an enormous way to the circulation of the blood. And these primary functions, you are going to see it now. The pumping of the blood is there, the circulation of the blood, the oxygen transport, the nutrient delivery, the waste removal, the maintenance of the blood pressure, the electrical conduction, and the vital organ support. You cannot see that it is actually a small organ about the size of what I told you, 10 size, the size of your fist, but performing enormous function for the body. And that shows the challenge that could come up by the time heart is affected. You see the oxygen transport notably is affected. The different parts of the body are not well receiving enough nutrients, and then the waste begin to accumulate that affect the pH of the body. Then the issue of maintenance of blood pressure cannot be gathered together again, cannot be well done, and that explains the issue of fluctuation in the blood pressure vis-a-vis the high blood pressure hypertension that is presented here. The issue particularly notably as we begin to get into congestive heart failure later on, the pumping of the blood is seriously affected, and that is the ventricle just unnecessarily get distended in the process. So come in please. So let's quickly go to, I'm not missing out something. Okay, let's go to the anatomy of the heart. The anatomy of the heart is structured in such a way that it is like a building. I want you to look at the picture of the house. The house, when it's being built, there's a foundation for it, then there is wall outside, then you have many rooms depending on the size of the house, then you have door to the house, then you also have pipes to the house, whether conduit pipe or surface pipe, the one carry the electricity, the one carrying the water, and that's the picture of the heart. Each time you look at art, for you to have a good understanding of it, look at it like that. So the chambers are like room. The valves that are into it, they are like the doors to the room, open and close like room doors. The blood vessels, they are like that pipe, while the electrical conduction system, they are the electrical power running through the body. So the art can easily be understood looking at this beautiful illustration that I've gotten. And then you will begin to see very soon what each of them actually does. Let's look at the heart walls. The heart walls is involved in the contraction and relaxation with the muscles sending the blood throughout the body. There is this layer of muscular tissue called the septum, that divides the heart wall into the right and left side. So we actually have two sides of the heart. We have the left side, we have the right side, even though each of those sides has something that it contains. So I want you to again have that picture that the heart is divided into two sides by by a muscular structure, a muscular tissue that is called a spectrum. It's like you bring your two hands together. When you bring your two hands together, the fingers, the tip of your fingers lying up on top of each other, having a hollow in between. You now imagine that hollow that you have made now being divided in between by a line. That is the septum that divides the heart into the right and the left. And the heart actually, the walls of the heart has three layers. That's what usually some of the terms you see coming up in reference or in discussion of the heart is patterned along these layers of the heart wall. There is what we call endocardium, there's myocardium, there is epicardium. Endocardium is the inner part of it, like it's endo, inside. When you see cardium all the time, it has to do with heart, cardiac, with that. So the name is picked from there, endocardium. That is inner part of the myocardium is in the middle. And don't forget, if you want to see some terms that you can use to remember, endo is inner, myocardium is middle. You are starting with that M. The epicardium, epi is the protective outer layer of it. I want us to take note of the fact that epicardium is one layer of a pericardium on itself, because pericardium is a protective sac that covers the entire heart, and it produces fluid that lubricates the heart and keep it from rubbing against the other organs. So the heart per se does not have issue of friction against the other organs because it has a fluid, a fluid sac called pericardium that through which it navigates itself, and then there cannot be rubbing with the other structure of the heart. This again explains what I've told us earlier on. See the inner part of it with this my cursor, that is the endocardium, the in-between. This is actually enlarged. And you see, by the time you look at the picture I'm giving it to you, like, it looks like something very big. No, it's like taking a section. Look at where this arrow is coming from. Taking a section of the heart, dissecting it and putting it under microscope. These are the cells it's going to break. This is the endocardium, the inner part of it. This is the myocardium, the middle part of it. And then there is the pericardium, that is outside part of it. And I told you it produces, there's some fluid here that makes it to be able to lubricate easily with the other organs. So we go to the four chambers now that I told you about. Don't forget, I told you the heart is divided into two sides by the septum. Now, the two sides now, the right and left on its own, they have two chambers separately. Heart on its own has four chambers, but divided into right and left by the septum, but each of them now has two chambers on its own. On top of it, when you look at it, as I told you to bring together with the tips of your finger resting on top of each other, all in between. Now, when it's divided by the septum into two parts, right and left, then you now see on the top of it too now is two. On top of it is the atrium, the plural of it called atria. We have the left one, we have the right one. Then on the bottom of it, the ventricle. So atrium is on the top, ventricles are down on it. So one on each other. Like, so you have the left atrium, the right atrium, the left ventricle, the right ventricle. Now, the right atrium on its own now has two veins, two light veins. What they do is that they deliver the oxygenated blood to the right atrium. Now, the oxygenated blood has to do with a blood that does not have oxygen, like the name suggests, deoxygenated. The oxygen there has been removed. The body does not just throw it out of the body like that. It has a way in which it circulates it all around so that you'll be able to now get refreshing. By way of refreshing, I mean get oxygenated somewhere there, and then it keeps circulating all over and over again now. So the deoxygenated blood gets into the right atrium. The superior vena cava is the one that carries from the upper body. I want you to take note of the vena cava now, vena cava veins now, the two light veins that are into the right atrium. There is the superior vena cava, there's inferior vena cava. You get good understanding of that the way I'm explaining this now. For the superior, everything from the other part of the body is carrying the oxygenated blood, get it into the atrium. Then everything from the lower part of the body, like the name suggests, inferior, the inferior vena cava, brings this to that, and both of them get it down into the atrium. Now, the right atrium then now pumps this blood into the right ventricle. You can now see a seamless process that takes place in the heart, that the way it is done, the way it is configured, the way the anatomy and the physiology of that body, of the heart is configured, is for you to be able to effectively carry out its designated role. Having discussed the atrium now, we want to go into the ventricle now. The lower right chambers pumps the oxygenated blood to the lower right chambers pumps the deoxygenated blood to the lungs via the pulmonary artery, and the blood itself reload the blood with oxygen, making it the unoxygenated blood of it. The oxygenated coming, it become oxygenated, it going around, do all its work, become deoxygenated in the process, and come back again to the heart to be refreshing with oxygenation. So when it gets to the right ventricle, the lower right chambers, they pump the deoxygenated blood to the lung, so that it is the lung that will now do it is inside the lung they will be able to get all the oxygenation, and then it gets it via the pulmonary artery out. Now, the left atrium is the left atrium now, upon receiving the oxygenated blood by the lungs. Don't forget, right atrium is deoxygenated, it gets. But the left atrium now, it gets the oxygenated blood from the lung through the pulmonary veins, which carry the blood to the left atrium. Now, the upper chamber left atrium then pumps the oxygenated blood to the left ventricle. Now, the left ventricle now, which is lighter than the right ventricle, and it's slightly larger than the right ventricle. And why it's slightly larger than that? Because of the action, the work is going to do. It pumps the oxygenated blood now to the rest of the body. So you can now get the circle in which I've explained it back. Let me get it back to you again. 4 chambers, 2 on top, 2 down. 2 atria on top, 2 ventricles downward. Then the right atrium on top, it has 2 light veins. The superior vena cava carry the oxygenated blood from the upper part of the body. The inferior vena cava carry the oxygenated blood from the lower part of the body, and then gets it down there. And then the right atrium now gets the blood to the ventricle, and from the ventricle it gets it down to the lung via the pulmonary artery. And then once it gets to the lung there, the oxygenation is done. And when then upon the oxygenation by the lung, it comes out through the pulmonary vein to the right atrium, and right atrium now go and empty it into upon oxygenation, the blood now gets into the left ventricle. Now, the left ventricle now is, as I said, is larger than the right ventricle because of the role it has to perform, pumping the blood to the rest of the body, which of course is the oxygenated blood. This is this slide 29 is a pictorial representation of what I've said in the last 5 minutes. You see, I call it the pattern of blood flow through the heart. I said deoxygenated to oxygenated. You see, this is the deoxygenated blood. It gets to the right atrium. From the right atrium, it gets into the right ventricle. From the right ventricle, it gets into the lung for the process of oxygenation. When it comes out of that place, through the pulmonary vein, it goes to the left atrium, and from the left atrium, it pushes it out to the left ventricle, and it's the left ventricle that will now be able to get this back to the body. And this is diagrammatically represented in the what I've explained to us here now. This is the right atrium now. You see the superior vena cava. Like I told you, the blue represents the oxygenated blood. You see the inferior vena cava. Inferior vena cava takes the blood, the oxygenated blood from the lower part of the body, and then the superior vena cava take it from here. It takes it into the right atrium. Right atrium, it gets it down into the right ventricle, and in the process of it, they get it through the pulmonary vein. Of course, the valve that I told you earlier on will be open so that it can go into the lung for the oxygenation process. And when it gets from the lung, it goes back to the left atrium, and the valves begin to open again, get it into the left ventricle, and from the left ventricle, it gets down to the body. And that's what the diagram here is explaining to us. You see, it's a process of bringing blood filled with carbon dioxide, remove every component of it, bring in oxygen to it, get it down to the body, because the oxygen is very vital to the normal functioning of the body. And when all those is depleted of it again, it comes back again. Like I said, that's what you see, the blue there, the deoxygenated one, and then the red there, the oxygenated blood. Now let's look at the valves. The valves is like the door between the chambers. In between, no matter, I want you to imagine door, no matter how it is, maybe a little panel door, maybe a well-fitted door, it separates things from one place to that. It's opening, allows something to come in. So it's open and closed system that it operates with. That's the heart valve to allow this blood to flow in, receiving signals in that respect. Now, because of this nature or the way in which it is configured anatomically, it prevents the backflow. There cannot be flowing back of the blood. It's always the front flow. So it cannot move in the wrong direction. Now, it has two AV valves, that is the arterioventricular valves, and then it also has two semilunar valves. So take note of that. The valves there, they are two AV valve, two SL valve, that is semilunar valve. Then let's look at the AV valve now. The AV valve actually open the upper and lower heart chambers. Don't forget, I told you the chambers have four, the heart has four chambers, but further divided into the upper part and the lower valve. Now, the two AV valves
We cannot hear you, sir. It looks like you're muted.
Maybe it's his network. By your network, we can't hear you.
We cannot hear you, sir.
Maybe it's his network.
So it looks like he probably dropped off. Okay, he has dropped off. We'll be back soon.
I'm sorry, network cut me off. Sorry, class. I hope you are hearing me now.
Yes.
Loud and clear.
Yes,
It's
sir.
okay. I'm sorry, please.
can hear
Network
you.
cut me off.
We can
Please,
hear
can I
you.
know when you last saw me?
Have you?
Which slide did you pick
Hello,
last?
sir. I'm going
You're
by. We are
talking
hearing
about
you.
Okay, which slide did you pick
yes,
last, please?
yes, you're talking about the two semilunar valves. No, you're talking about the atrioventricular valves. So you're in a different slide
Sir, your
now.
network is still shaking. Your network is still shaking.
It's okay. Let me wait from 2 minutes whether it's going
Exactly.
to be better.
Heavy valve.
Yes, sir. This is where you were. You were talking about the
Oh,
two atrioventricular valves when you cut off.
it's okay. Thank you so much. Is my voice stable now?
On my own end, you're stable now.
Okay.
Yes, it's okay now.
Other people, please give me feedback. Is it stable?
Yes, can hear you very well.
Okay.
Yes,
Thank
okay,
you
you
so
can go
much.
on.
Let me move on. Thank you. Let me repeat the AV valve. Like I said earlier on, as part of the foundation to our workshop, I told us about the heart has 4 chambers, and which is further divided in the middle into 2, and then we now have 2 upper, 2 lower. And I told you there are different components of the heart. The aspect we were discussing before the network cutoff has to do with the AV valve, the atrioventricular valve. And I told you all that 2 types of it exist. We have the tricuspid valve, which opens the door between the right atrium and the right ventricle. Then we have the mitral valve, which opens the door between the left atrium and the left ventricle. And I was trying to show all the infographic that are actually explain that. This is the tricuspid valve, this is the aortic valve, this is the bicuspid valve. Then from there, I move on to the SL valve, which is the semilunar valve. I said this opens when the blood actually flows out of the ventricle. Don't forget, I told us the way valve is made in such a way that there is no backflow. It allows blood to go in the right direction, not in the wrong direction. And 2 semilunar valves actually exist. We have the aortic valve, like you see the infographic in slide 34 there. The aortic valve opens when the blood flows from the left ventricle to the aorta, which carries the oxygenated blood. While the pulmonary valve opens when the blood flows from the right ventricle through the pulmonary artery, which only carries the oxygenated blood. Don't forget the difference between the pulmonary artery, pulmonary vein. Pulmonary vein will carry the oxygenated blood, while pulmonary artery will carry the oxygenated blood. Then we need to, having discussed the valve now, we need to look at the blood vessels, which is like the pipe carrying the water into your house. So the channel of pumping the blood from the heart and returning it to it is the blood vessel on its own. And there are 3 types of it. I'm going to explain the issue of blood vessel very, very well, because it is very significant to our discussion today. Because if you get it, you will understand what is really happening. I'm sure we've done some piping, even though we are not core engineers, we've witnessed some piping or in the house or in our neighborhood, in construction places where pipe is laid. You know, when pipe is newly made, laid, we see how fine it is. The internal part of it, the diameter of it, is likened to what I call the lumen of the vessel. Water flows easily. But over time, you see some deposit inside that pipe, and then maybe because of corrosion, if it is a metal pipe is the one easily susceptible to that corrosion. Let me use that example, even though we can still use the plastic pipe too, for example. But you see over time, you see some deposit inside. I want you to take note of those deposits and put it behind your mind. We are going to discuss it and have reference to it in the course of time. So we have 3 types of blood vessel, so to say. The arteries, they carry the oxygenated blood, but don't forget, I told you the extension. Don't forget this difference between the pulmonary artery and the pulmonary vein. Pulmonary artery carry the oxygenated blood because it takes air to the lung. Then when it comes to its pulmonary vein that gets the oxygenated blood out. So note that's the exemption to it. So arteries, they carry oxygenated blood with exception to pulmonary artery. Then veins carry deoxygenated blood with exception to pulmonary vein, which carry the oxygenated blood. Then there is now capillary. When we talk about blood vessel, you look at three things. You look at the artery, you look at the vein, then you look at the capillaries. The capillaries, they are small blood vessels where blood exchanges oxygenated blood and deoxygenated blood. And this is the picture I was trying to paint earlier on concerning piping system in a construction site or in houses or in offices. You see now, this is the blood vessel that I just discovered. This is the normal cross section of it. Now, when it goes into vasoconstriction, the diameter, you see it now, the lumen is smaller compared to this. This red portion is the lumen. This is what the infographic is showing to you, and you look at my cursor. This is the normal blood vessel. This is when it is into vasoconstriction. Then this is when it's to vasodilatation. It widens out. And you know, all of them has its own impression on the flow, or has its own impact on the flow of the blood. We now look at the coronary arteries. Heart actually receives through nutrients from blood, like I said earlier on, through different networks of vessels here and there running through the heart. Now, the left coronary artery branches into two, which are the one we call circumflex artery and the left anterior descending artery. The circumflex artery is the one that supplies blood to the left atrium and the back side of the left ventricle. While the left anterior descending artery, they are the one that supply blood to the front and the bottom of the left ventricle. And also that septum I told you that divide the heart into the right and the left portion. Then the right coronary artery on its own is supplied blood to the right atrium. So you left ventricle, the right coronary artery to the right atrium and the right ventricle. So you cannot miss that one. Exception is only the pulmonary artery, pulmonary vein I talked about. And this infographic further explain the movement of the location of each of those vessels that I talked about. Then, of course, this is more explicit further. Then this also talks about the arteries. I told you this is the left coronary artery. I told you to the left. Then this is the right coronary artery to the right of it. Please don't forget that. Very, very important. Then let's look at the conduction system. I told you in the picture I gave earlier on when we started our lecture that look at the way your house is wired. Very, very important. So we look at the electrical conduction system now. This is what determines the artery. This is what determines the beating of the heart. And it's actually start from the top of the heart and move down to the bottom. That is the way the signal is sent, like signal being sent from your head to your toe. I want you to have that picture behind the mind as you get to understand what electrical conduction system is. The electrical conduction system includes these two nodes, the SA node and the AV node. The SA node sends signals that makes the heart beat, while the AV node, the atrioventricular node, sends signals to the heart chamber and to the lower chamber of it. The upper chamber and the lower chamber, they receive signal from the AV node. The SA node sends signal for the heart to beat. So those are the one now, SA node and the AV node. Now, still talking about the electrical conduction system, we have the left bundle branch, we have the right bundle branch. The left bundle branch sends electrical impulse to the left ventricle, the right bundle branch to the right ventricle. So you can also miss that. Again, when you talk further about the conduction system, you know the bundle branch either left or right. The left to the left ventricle, the right to the right ventricle. Now, there is also bundle of His, which sends electrical impulse from the AV node we talked about earlier on to the fiber we call Purkinje fibers. It is the Purkinje fibers that make the ventricles to contract and pump out blood. So that is also clinically significant now. The Purkinje fiber, because of the work they do, anything that affects the Purkinje fibers will affect the contraction of the ventricle, will affect the pumping out of the blood, and that is what another infographic I'm trying to explain. Look at this septum I told us earlier that separate the heart into two aspects of it. This is the left bundle branch. This is the right bundle branch of it. And this is the SA node. This is the AV node. Yeah, so we move on now. This explains the conduction system I told us about. I told us that there are two nodes, the SA node and the FA node. And then talk us about the Purkinje fibers that helps control the contraction of the ventricles so that they will be able to push out blood. At this point in time, I want you to stretch your leg. We are 1 hour into the class. Stretch your leg before I go into slide 50. Please stretch your leg and stretch your hand. After that, I go into slide 50, we continue. I leave 1 minute for us to get that done. Please stretch your leg and your hand. Stretch your leg and your hand as we move on. We'll be back in class in the next few seconds. Please stretch your leg, take some little water, sip some water as we continue in our workshop. We'll be back in the next few seconds. Now you are welcome back to the class. I hope we are back together. Are you hearing me, please? Are you hearing me, please?
Yes, we can hear you very well.
It's okay. Thank you very much. One
Yes,
of the
I
things
can
you
hear
have
you.
to also be conversant with is the issue of preload and afterload. You can't get good understanding of the functioning of the heart without having these basics well known and well understood, because they become reference points subsequently in disorder, in cardiac condition, and as we also finally land into our subject of discussion today, that is the congestive heart failure. So we look at the issue of preload, we look at the issue of afterload, we vis-a-vis also look at the issue of contractility. Let me first of all look at the contractility. Of course, we are physiotherapists, we know what how contraction of muscle is very significant to movement. And that's also the issue, the what plays out in the heart. The contraction of the heart muscles play a lot of role in the movement of the blood in the heart. By contractility, we mean the intrinsic strength of the cardiac muscles that I've explained to us earlier on, which is independent of the preload, but a change in preload actually will affect the force of contraction. And what is preload? Preload itself is the initial stretching of the cardiac, the stretching of it. Like you bring your two hands together, stretch out your elbow, and then your shoulder too is like abducted in the process of it. That gives the picture of the preload, and it has to do with ventricular filling. Network is failing. Let me hold on. I hope the network is back now.
Yes, we can hear you.
Okay, thank you very much. So that has to do with preload. It is stretching. Stretching of the cardiac muscles. Try to stretch out your shoulder, your hands moving apart. That provides room. It makes room, and that is what brings out the ventricular filling. Afterload is almost like opposite to it, which is the force against which the heart now has to contract to eject the blood out. So it's a very simple term. It looks big when you come across it, preload, afterload, and that's what determines the efficacy of the heart and becomes a reference point when you begin to talk about the functionality of the heart. So preload again, the initial stretching that allows the ventricular filling. Then afterload, it is the force that helps to contract and eject the blood out. And that brings us back to the contractility I was discussing earlier on, that it is the intrinsic strength of the cardiac muscle which is independent of the preload, but a change in that stretch will affect the force of contraction of it. When there is a change in the preload, it will definitely affect the force of contraction. When the stretch is not so much, the force of contraction will not be much, then the ventricular filling too will be affected. All this comes to play in the issue of heart disorders. And that's what now sequentially brought us to the heart conditions and the disorders. After knowing the real anatomy and the physiology of the muscles of the heart and the heart structures, we now begin to navigate
I cannot hear the speaker. Oh. Am I the only one?
We cannot hear you again, sir.
particular organs.
We
Now,
cannot
the heart
hear.
disease. Okay, you are not hearing me again?
It breaks occasionally.
Are you hearing me? Are you hearing me?
Yes, I can hear you
Are
now.
we together? It's okay,
I
thank
can
you.
hear you now.
Everybody, please, are you hearing me? Okay, fine. So let me continue.
Yes, sir,
I
we
said
can
we have
hear
been
you.
able to successfully,
We can hear you.
successfully lay foundations. So we are now going to the disorders of the heart conditions. And I did say that heart disease is a leading cause of death worldwide. It's possible to have arrhythmia, which will be like the heart beating too fast or too slow, or when there is an irregular beating of the heart. It's also possible to have a cardiomyopathy has to do with unusual thickening, unusual enlargement and stiffening of the heart. All these affect the functionality of the heart. And that's why Reverend will come with this kind of indications that there's a patient is having arrhythmia, the type of arrhythmia it's having may be stated, or it's having cardiomyopathy, which has to do with the thickening of the structures of the heart. And when it thickens, it does not really confer an advantage per se on the muscles of the heart. Rather, it affects the functionality of the heart. Still talking about the heart condition and disorders. Now, apart from those arrhythmia that I talk about, the cardiomyopathy, it's possible to have CAD, which is coronary artery disease. Coronary artery disease, I was explaining something to you earlier on about laying on of pipe to construction site or to houses. I told you to look at that pipe very well when it's laid, visualize it. Now, over time, if it's the metal type, you see a lot of rusting taking place internally, which effectively reduces the diameter of that pipe carrying water to the house or to the construction site. That inner coating, that rusting and deposits of some dirty there is what you can call plaque. It builds up in the process of time, just like rusting builds up inside that metallic pipe, and also dirty also builds up inside it. So the plaque builds up over time in the artery because of some disease condition, and this building up again is not to an advantage. It narrows the artery. And I want you to fly your mind back to the infographic I gave you earlier on about the structure of the vessel. When the lumen begin to close up, it also brings a lot of struggle for blood to be able to move in. And one of the disorders of the heart is what we are focusing on today, which is called CHF, congestive heart failure. But in some instances, you will see it being written as HF, heart failure. Now, in this instance, the heart could be so stiff or too weak to be able to carry out its normal functioning of pumping. You see, the pumping of the heart is like an index of functionality of the heart. And so, in the cardiac congestive heart failure, now whereby it's either too stiff or too weak to be able to carry out its functioning. Network is fluctuating again. Let me hold on for some seconds. It's okay. Are we back together? Are you hearing me, please?
Yes, we can hear you.
Okay, fine. So the next kind of disorders again is diabetes, which has to do with sugar, the fluctuating sugar in the blood. And of course, that's also the reason why we monitor all this in our patients from time to time. Perpetual uncontrolled diabetes will give an heart condition. Then there is also heart attack, which is also one of the common reports, heart condition that is reported, which is called myocardial infarction. That one has to do with sudden coronary artery blockage. And once it blocks, it doesn't confer any advantage again, rather that it brings a challenge to the body because the oxygen is cut off to part of the heart. Of course, the structures of the cardiovascular system I told you about, which is one of them is valve, it too can begin to malfunction. When they begin to malfunction, there could be heart valve disease. Of course, high blood pressure is a common condition patients are presented with, and it's also as a result of a heart disorder. It's a heart condition. In this instance, the blood begins to flow fast against the arterial wall. Again, this does not confer any advantage again because it has to begin to now get a compensatory mechanism to be able to withstand the stress of that rapid flow of the blood through the arterial walls. Then, of course, there's high cholesterol, in which is too many fats in the blood, and this again can cause the inner plaguing of the blood vessel to narrowing down the lumen and increasing the force through which the blood can flow through it. Of course, the pericarditis, when there's inflammation of the heart lining, the pericardium, is also a heart condition. Now, having known the conditions that are present in the heart, we also want to know fundamentally what you see in the signs and symptoms in conditions of the heart. Notably, we have issue of chest pain. Down the line, I'm going to explain how that comes to be. There is heart palpitation. Heart palpitation in the instant, it will be as if the heart, the commonest way to explain is the heart is doing unnecessarily just begin to beat that way. Then there could be dizziness, there could be shortness of breath. In fact, this shortness of breath is characteristics of heart. In the process of this discussion, the process of this presentation in this workshop, probably sometimes in the afternoon, you will see me making reference to one of the outcome measures that is usually used to either monitor treatment or to do grading of heart condition. You see that one is called New York Heart Association classification. It borders on the issue of breathlessness. So the issue of shortness of breath is characteristics of heart condition, even though it can also be in some respiratory condition. Anyway, then the fatigue there is it. Easy fatigability is one of the issues of the heart condition. Then lower leg swelling, which will be characteristic of the congestive heart failure we are going to discuss later on. So the tests that are usually done in heart conditions are BP measurements, electrocardiogram, ECG or EKG. We have the echocardiogram. Then there's a chest X-ray. There are blood tests. There's computed tomography CT. There's heart MRI. There's stress tests, which instance will be physiotherapists who will be relevant in it. Cardiac catheterization is also one of the tests that can be done. So having successfully laid all this foundation, which talks about the cardiovascular system, how it can be, how it is laid down for it to be able to successfully perform its function, and we've been able to now connect it to the disorders that takes place in the heart. We can now successfully begin to navigate the congestive heart failure, which is the main subject of our discussion in this workshop. I want you to look at this picture of the heart failure. Look at it with split of seconds, and that is essentially what we begin to talk about. Once it happens, a cascade of events begin to throw up in the body. We're going to look at the cause. We're going to look at the issue of the ejection fraction, whether the ejection fraction, the EF, is reduced, whether it is preserved. We're going to look at it. We're going to look at the issue of the epidemiology of it. We're going to look at the problem that can emanate from it, and we'll begin to look at how it can be diagnosed, and then we'll look at how we come in as a physiotherapist. This again shows what it looks like in congestive heart failure. There's fluid around the lungs, as you can see there. I'm sure you begin to cast your mind back to some classical cases probably you have seen on the field, or probably you don't even know the diagnosis. You could see people of this nature. You begin to see what must have actually happened in them. There's a bloated stomach, and then there's a swelling of the legs, which is one of the things I talked to you about, is characteristics of heart condition. Then you look at the picture of the normal heart, you now see this enlarged heart. It's like gorged. It's like many things is loaded there, and it's not being able to push out what it is actually having there. Still talking about it again, this is going to be the pattern in which we are going to do our discussion. We're going to look at the different types of it. We look at the signs. We look at whether it's going to be, there's what we call right-sided heart failure. There's what we call left-sided heart failure. We look at the pathophysiology. We are going to also look at the causes of it in the process of time as we move on. Then the congestive heart failure has to do with the inability of the heart to pump oxygen-rich blood to meet the needs of the body. We have agreed through the foundation that was laid that body needs oxygen to thrive, to be able to perform its normal function. In fact, it's multi-system affectation. Heart has multi-system affectation because the different system of the body need oxygen to be able to function normally. So there's what we call right-sided congestive heart failure. There's left-sided congestive heart failure. This is the point that I want you to pick very well. And I'm going to take some few slides to try to dance around this in different perspectives for you to be able to have a good understanding of what we are talking about. The right-sided congestive heart failure, what it means is the heart is too weak to pump enough deoxygenated blood to the lung, to send deoxygenated blood on the errand to the lung, go and get oxygen. So in that right-sided congestive heart failure, it is too weak to be able to pump blood there. And that's why you see the gorging. Let me fly back into this. That's why you see the gorging. Can you see the gorging? So big compared to this aspect. Look at this, where my cursor is. This is the normal heart. Look at it now, because the blood is now there, it cannot be pumped into the into the lung for it to be oxygenated. It becomes big. Yeah, so that is right-sided congestive heart failure. The left-sided congestive heart failure has to do with the inability of the heart to pump enough oxygenated blood to the different part of the body through the left side of the heart, because it's malfunctioning. So it doesn't have that requisite strength, stretch to be able to push it out. And this will either be due to the fact that it's either too thick, too stiff, or either too weak to be able to get the work done. So there is right-sided, there's left-sided. Right-sided has to do with the heart being too weak to pump the deoxygenated blood into the lung for oxygenation. The left-sided has to be that it's not able to pump the oxygenated blood through the left side of the heart to the different parts of the body. Let me go back to this again, and that explains the gorging, the bigness that is now there, because it's containing a lot of things that normally flow into you, but it's pushed out. But because it cannot be pushed out, you see it now becoming unnecessarily big. I've gone through all this. We move on now. Having explained the left-sided and the right-sided, I still want to use a term to explain this further. We talk about the low output and the high output. In the low output failure, there's no enough cardiac output is made available to meet the body of the demand of the body, and that should tell you that that is the right-sided excuse me. Now, the low output and the high output, let me explain it again. In low output failure, there's not enough cardiac output to be able to meet the demands of the body. And if we now relate it to what I was explaining earlier on, that has to be with the left-sided cardiac failure. Now, the high output failure occurs when the condition causes the heart to work harder to meet the demands of the body. Now, there could be diminished cardiac output, which results from the peripheral tissue perfusion, and there could be congestion of the lung and peripheral, which may occur when the patient develops acute pulmonary edema. So this is what really appears the picture I want us to understand concerning the cardiac heart failure. Low output failure, high output failure. Low output failure when the cardiac output is not able to meet the demands of the body. The blood cannot be pushed out, like I explained here in this instance, and that has to do with the left-sided one. There can also be high output one when a condition causes the heart to work harder to meet the demands of the body. So these are another dimension that I want you to understand. The slide I'm going to now, which is slide 64, is very critical. because it's very important in the diagnostics by the time we begin to get there. Now, it has to do with the ejection fraction that I talked about. The left-sided has two types. The left-sided failure I told you about, which has to do with the too weak to be able to pump blood to the different part of the body to meet the functions of the body. It has two types per se. Now, there is the one we call systolic heart failure, or the one we call diastolic heart failure. Even though in the process of it, this has been introduced into it, which is called middle range, middle range ejection fraction. Now, but it's essentially systolic and diastolic. Most systolic heart failure means that the heart failure is with reduced ejection fraction, and then which is probably less than or equal to 40% ejection fraction ratio. I will talk about ejection fraction ratio very soon. Now, but the diastolic one is it doesn't have reduced ejection fraction. It has preserved ejection fraction. And that's what this P you see there. This is heart failure preserved ejection fraction. This is heart failure reduced ejection fraction. When you see heart failure reduced ejection fraction, that is what is called systolic heart failure. And in that instance, the ejection fraction will be less than or equal to 40%. For the diastolic heart failure, there is preserved ejection fraction. It is preserved. The pumping will have greater or equal to 50%. That is the ejection fraction. But I told you there is a middle range that is being introduced in between them. And that's why anytime you see HFMREF, it talks about heart failure with middle range ejection fraction. In that instance, the ejection fraction will be between 41% to 49%. And the question you're going to ask is that, where are these figures coming from? You will see that on the report of the echocardiogram. So that is very significant. I want us to pick. Now, explaining further the systolic versus the diastolic heart failure, both of them actually affect the left ventricle. I want us to take note. They affect the left ventricle. But what happens in systolic heart failure is that the heart muscle is too weak and the ventricle cannot contract normally. That is what happens. Whereas in diastolic heart failure, the heart is too stiff. The ventricle can't relax normally. So you pick that. In systolic, it is too weak.
Network problem.
Network is fluctuating. Let me stop. I'm back now. The network is back. I hope you are hearing me.
Yes, we are hearing you, sir.
Okay, now let me contrast the systolic and the diastolic again. The systolic, the muscle is too weak. In diastolic, the muscle is too stiff. So in both instances, it affects the functioning of the ventricle. Don't forget the fact that I said that this failure affects, both of them affect the left ventricle. They affect the left ventricle. So in systolic, again, I repeat, the muscle is weak. In diastolic, the muscle is stiff. Whether it's weak or it's stiff, it affects the normal functioning. When it is weak, the ventricle cannot contract normally, just like look at your conventional muscle. When the muscle is weak, the functionality of that muscle is affected. Also, when the muscle is stiff, you also know that its contractility is also going to be affected. So in both instances, they are affected. Now, that is systolic and diastolic heart failure. Now, when we go into myocardial dysfunction now, that's the one I've explained to us later on, earlier on. I told us that both of them actually affect the left ventricle. Systolic dysfunction, again, the left ventricle has reduced muscle contractility. In diastolic, there's decreased left ventricular filling because what is also too stiff. It's stiff and it cannot relax. You know, when a muscle, like half a rubber, this rubber they used to weave here, it has lost, it's too stiff. It's not like when it's newly bought. When you stretch it, it takes time for it to come back, so it cannot perform its normal function, and that's what causes the dysfunction in the heart. Now, this now shows again to what I said earlier on to explain it out in way of infographic. Now, you see the systolic heart failure, it can't pump. And in diastolic heart failure, it doesn't have enough blood to fill it because, of course, you see the volume that is here now. Now, blood backs up from the lung, now stays there, and then that's what causes a lot of distension that causes of congestion of the fluid. And that's why you see now that the cardiopulmonary specialists have a lot of role to play, attending to the cardiac function, attending to also the longer function of the patient. We move on. Now, talking about the right-sided heart failure now. The right-sided heart failure occurs as a result of the left-sided heart failure. I want you to look at that connectivity. One leads to the other. When there's left-sided heart failure, there is tendency to have the right-sided heart failure, because when the left side cannot pump out, of course, you know it's going to affect the right side too. So when the left ventricle fails and can't pump enough blood out, there's increased fluid pressure, which transfer back through to the lung. And this actually damages the right side of the heart, making it ineffective to be able to do its work normally, to get the blood back to the lung. And that shows the reason why blood is now seated there, not being able to get into that place to go and get oxygenation. Don't forget what I said again. There is a background left ventricle failure, left-sided ventricle failure in the precursor to the right-sided one. And this can easily be explained now by the fact that there is increased pressure, because the left ventricle is not pumping out enough blood. There's increased pressure, which passes back, which transfer back onto the lung. And once it transfers back onto the lung, the structures of the heart become damaged. And when they become damaged, that affects its pumping ability. You see the blood seated there. That brings me to the ejection fraction ratio I was talking about. Don't forget, in 2 slides away, earlier on, I was trying to differentiate what happens in the left ventricular failure. I told us that there could be, with reduced ejection fraction ratio, in which instance the ejection fraction could be equal to or less than or equal to 40%, but there could be preserved one, in which instance it will be equal to or it will be greater than 50%. And I told you that it could be middle range heart failure in between. So this is the ejection fraction ratio now that we are talking about now. The ejection fraction, you see it on the echo as EF. The ejection fraction has to do with the total amount of blood that pump out with each beat of the heart, and it is measured in a percentage. Now, the process of getting it done, echocardiography, the commonest one I told you, other ones are cardiac catheterization, MRI, and CT scan, but the commonest one is the echo. And you see that once you pick up your echo form, look at EF. It's almost always the downside, left side of that form. You see the EF, it will be written there. When you pick it, you knock it into what I taught us earlier on in slide 64. You will know where it belongs to, whether it's systolic or diastolic. Once again, systolic, it is less than or equal to 40% ejection fraction ratio, while diastolic is either greater than or equal to 50%, but the middle range will sit between 41% and 49% of it. Now, when you look at these values again, when you see higher than 75%, it can indicate a heart condition like hypertrophic cardiomyopathy, which is source of referral that we reduce to. It's also a source of sudden cardiac arrest in patient. And when the EF again is less than 40%, it may confirm the diagnosis of heart failure. So EF is something you must not miss out. EF defined once again, it is the total amount of blood that the heart pumps with each beat, and it's in percentage. And this where my cursor is laid down now talks about the high function of it greater than 70%, normal function of it 55 to 70%, low function of it 40% to 45%, and possible heart failure less than 40%. And this again goes ahead to explain what ejection fraction is all about. From this, we go into the epidemiology of cardiac congestive heart failure. Congestive heart failure actually increases with age, and 1 to 2% of the population are less than 55 years of age. Less than 55 years of age. 1 to 50% of it, they are less than 55 years of age. And then it increases to a rate of 10% for persons older than 75%. So you see it presenting across ages. 1 to 2% of it presents 1 to 2% of it presents in less than 55 years. 1 to 2%, there's increased rate of 10% for people that are older than 75%, though it can actually occur at any age. I want us to have this behind our mind that it can occur at any age. It can occur at any age. It can occur at any age, know it. But there are some ages that makes some for it to occur more, and that is 10% of it is increased in people that are older than 75 years, and 1 to 2% of it in people that are less than 55 years. Now, approximately about 6.57 million Americans that are greater than 20 years of age really have this condition we are discussing today. And this is actually expected to rise to as much as 8.5 million by 2030, according to a study done last year. So it is projected that there will be increase over time. Then about an estimated figure of 960,000 will have new cardiac heart failure yearly, whereas about greater than 64 million people will have cardiac heart failure worldwide. That means a condition that world looked at and that we are going to come across on the field, and it's a source of morbidity and mortality wherever it is presented. Now, heart failure is actually a major global health concern, and it's a risk factor in advancing age. Like I've said, the risk factor includes sex, in instances where there's inherited cardiomyopathy, where there's diabetes, where there's obesity, you have increased form of it, still explaining out the epidemiology. In Africa, in our client here, the cardiovascular disease actually account for 70 to 10% of all medical admissions to our hospitals. And out of this, heart failure contributes a significant proportion of that 7 to 10%, and like 3 to 7% of this proportion. That means also something that is well presented in our hospitals across our climb in Africa. Then Kenya reported about 32% rheumatoid heart disease as a causative factor of heart failure. Actually, rheumatoid heart disease is more common in their climb over there in Kenya, the East African bloc. As you see, it is some epidemiological factor I'm going to show onto us. And then out of it, 25.2% of it actually results from cardiomyopathy. An hypertensive form of it is 17.6%, which is actually a bit of variant to what is presented in our country, which I'm going to show to us earlier on. Now, this actually may be due to the high prevalence of rheumatoid heart disease in West Africa that I told us earlier on, which about 1 in 7 people in that climb do present with rheumatoid heart disease, and that shows the preponderance of rheumatoid heart disease being causative factor of cardiac congestive heart failure. Still talking about Kenya, the associated factor with patient deterioration leading to admission. You know, we are talking about admission and readmission cycle. There is that inadequate therapy is an issue, arrhythmia is an issue, repeated infection is an issue, anemia is an issue, infective endocarditis is an issue. And when you look at all this now, you see that there is always a way that will come in as a physiotherapist in all this presentation to be able to manage them, looking at the reason why there is deterioration in their condition that necessitated admission there. And to Ghana, the commonest risk factor in this congestive heart failure is hypertension, almost similar to Nigeria's own, which I still going to talk about there. Then also, the previous history of heart failure is there. Family history is also an issue there. Then from there, we come to Nigeria. Hypertension is the commonest cause of congestive heart failure in Nigeria. 61.5% of it the population reports this, according to a study done sometimes in 2009 in Abuja there. And another one done in Abeokuta talks about a slightly higher figure, still making hypertension to be preponderant. That's 64.3%. And out of it, the systolic hypertension contributes 75.5%, and then 23.5% has to do with heart failure with preserved ejection fraction. I'm sure you can fly your mind back to the slide I gave earlier on. I said it can either be with reduced ejection fraction or with preserved ejection fraction. If you recollect very well, with preserved ejection fraction, I said that the ejection fraction would be greater or equal to 50%. And that's according to this study now done in Nigeria, the second one in Abeokuta, precisely that. This is the picture again of the congestive heart failure. I want you to look at the left side there. I want you to look at the right side there. I want you to look at this jugular distension, the side of the neck. You see it like a bulging. There, you can't miss it out in the examination of the patient. When you talk about the running of the sternocleidomastoid muscle, about that area, you see it being distended. That is what they call jugular distension of the vein there. Then this is the pulmonary edema that can result as a result of it. And because of this, there could be hepatic congestion. That is the interrelation of all these two. And also you remember that 25%, about 20 to 25% of blood goes into the kidney. That's why you see kidney 2 not being spared in that instant. Now let's look at the causes of congestive heart failure. From the data I have provided from the epidemiology, it will be very obvious to us. I'm just going to list now the causes of congestive heart failure. It can develop from any of these long-standing medical conditions. Conditions like arrhythmia, either breathing fast or slow, irregular heartbeat, cardiomyopathy, congenital heart defects, coronary heart disease, endocarditis, heart attack, all of them can be there. Now, I appreciate this infographic very well because it further explains out what I explained to us earlier on concerning the lumen of the artery. This has to do with coronary artery calcification. Look at the normal artery, just like the pipe or the hollow of a pipe. Can you see there? Now, so look at the plaque now that has built up over the time, the calcification of it, the intima layer of it. This is now you can see the effective diameter of the vessel that is left for the blood to flow. That causes a lot of buildup of the pressure, and for it to be able to maintain the flow, which is reduced now, it has to bring in a lot of compensatory mechanism to be able to allow the flow to be normalized. Of course, that on its own has its consequences, which I'm going to explain to us very soon. Still talking about the causative factor of congestive heart failure, there's heart valve disease, there's high blood pressure, there's blood clots in the lung, there's diabetes, there's severe lung disease like COPD, and then obesity too can be a cause. But over time, and like I said earlier on, left-sided heart failure lead to right-sided heart failure. And these are causes, different way that I've tried to put it in diagrammatic form so that we can be able to appreciate it, still explaining further what I've said earlier on. The risk factors in congestive heart failure is this. From the epidemiology that I told you earlier, I say it can occur at any age. Even though at a particular age, there's some percentage that is about 1 to 2%, is like maybe about 50-year-old, and once it's getting to about 75 years old, you see the percentage increase is about 10%, but it can occur at any age. So it affects both sexes, but men actually often develop it at younger age than women. And the chances of developing heart failure actually increases in 65 years and older. That may be attributable to the aging effect, and then the stiffening of the heart muscles. The family history of such will also be the reason for it. Then gene changes that affect heart muscle too is a factor that has been picked up. And risky habits harmful to the heart, like smoking, salty food, and that's why you see about lifestyle changes. That's what brought the dimension of lifestyle changes in the management of heart conditions. So harmful habits have its own effect on the heart. Smoking, salty heart, fatty food, inactive lifestyle, physical activity, and that explains our relevance too. And that explains the continuous campaign concerning healthy lifestyle, physical activity. It cannot be overemphasized. And the issue of alcohol ingestion too. There's this thing we call AUD, alcohol disorder, alcohol use disorder. It can also be a risky habit that can predispose to cardiac heart failure. Then also drug use, illegal drug, unprescribed drug use. It can be a risk factor. Still talking further about risk factor, other medical conditions that can affect the heart, like high blood pressure, serious lung disease, infections. Like during the time of COVID-19, we saw it that it put people at risk of COVID-19 and then worsening the condition, the pre-existing condition. Then African American, there's risk factor. When the income, of course, the socio-economic factor can be linked to this in the sense that the person will not actually be able to maintain his medical life being managed very well. And if the person is not well managed in terms of treatment, it can further predispose the person to some other danger. Of course, the education geographical region will be there. Now, the symptoms of the congestive heart failure now, whether right or left, we want to begin to navigate it now. It actually depends on the side that is affected. And that's why you see, if you see the picture and infographic I brought in about 4 or 5 slides away, is deliberate. That infographic show what happens on the right, what happens on the left. The presentation a bit differs, even though there's a bit of commonality in it. So most symptoms are actually caused by reduced blood flow to the organs. When anything you see happening, you see it happening in some other area there, you can trace it to the fact that the organs are not they are not well circulated with blood, the oxygenated blood. And then the build-up too of the fluid is there, the reduced flow of the blood through the heart is there, and then the inability of the blood to push blood back to the heart is there, and also to be able to push into the lung. It's like a cyclical event here and there. Then the shortness of breath upon activity when the patient is climbing stairs is the first symptom that is noted. I told you later on, I'm going to talk about New York Heart Association classification. You see that actually had to do essentially with shortness of breath. So when you begin to see shortness of breath, you begin to talk tilt towards this presentation there. The fatigue and weakness even after rest is there. Coughing, the swelling and weight gain, which can easily be explained to the fact that there's a fluid buildup in the lower part of the body. Don't forget the scenario I told you about this superior vena cava and inferior vena cava. I told you that superior vena cava takes all the reduced, that's the oxygenated blood back to the heart. From the upper part of the body. I told you that the inferior vena cava takes from the lower part of the body. And in this instance, now there is build-up because those ones are not taken up so easily. So then there's sleeping difficulty when lying flat. And that's why you see the positional advantage is Fowler position for some of us that were conversant with it. But for those that don't know, Fowler position has to do like you're assuming like a half supine lying, like you tilt the head of the bed up a bit. It will be the comfortable position for them. Of course, the issue of loss of appetite, which can be leads to the fact that enough blood is not flowing through the system, and the digestive system is not enough to be able to perform its own function. So there is no appetite thrown up to receive more of food. Of course, swelling in the neck vein, which I've shown on to us there, tubular distension vein, and then the need to also urinate often is there. This now shows to us the difference between the right-sided heart failure and the left-sided heart failure, the different presentation. Now, the left-sided one now, because there is ineffective left ventricular contractility, there is a failure of left ventricular contraction, there is decreased cardiac output to the body, and because there is decreased cardiac output to the body, the blood back up into the left atrium and lungs. It build up. Then there is pulmonary congestion. That's what causes the dyspnea and activity intolerance for the patient. And that's the point we take into consideration in our management of patient. For the right-sided heart failure, there is ineffective right ventricular contractility. The right ventricle is not able to function with its pumping ability of blood into the lung. Then there is decreased cardiac output to the lung as a result of that. And because there is decreased cardiac output to the lung, the blood back up into the right atrium and peripheral circulation is affected. And this is what leads to the weight gain and peripheral edema and enlargement of the kidneys and other organs there. So there is a difference in the presentation, whether it's in right-sided or in left-sided heart failure. At this point in time, I want to give us 3 minutes to stretch ourselves. We've taken another almost 50 minutes on. Let's stretch ourselves. By 11:45, I'll be back. Are we together?
Yes, sir. We
Are
can
we
hear you. We are
together?
together. Yes, sir.
Yeah.
We are together. I can hear you.
Okay. Please, let's go together.
Yes, sir, we are together.
Okay. Now welcome back to class. Welcome back to class.
Welcome back, sir.
Yes, thank
Come
you.
back, sir. Yes,
I
sir.
hope you have been able to stretch your leg.
Yes, sir.
Yes, sir. Thank you.
Keep
Thank you,
going.
sir. Yes, sir.
Thank you. Yes,
All
I
right.
thank
have a
you.
question, sir.
So, okay, go ahead.
So I'm wondering that since we usually have the person is likely to have left-sided failure before right-sided failure. Is that true?
Yes.
That means if the person's legs are swollen, the chances are the person already passed the stage of left-sided failure.
Yes.
That means if the person's legs are swollen and we were thinking about challenging the person, we'll be thinking more from the perspective of the level of perfusion, that is percentage of perfusion and level of tolerance of exercise. Would that be right to think so?
Yes. Yes.
Okay, thank you, sir.
You see, the issue of tolerance is something we have to combat with in the management of. You see, I'm going to actually go extensively into physiotherapy very, very soon. Probably almost about 40 minutes or 1 hour's time. It's something we have to face. This is the dyspnea I told you about. So it makes the patient to struggle to do, but that does not negate intervention. There's a way it's going to be strategically attacked, strategically handled when we get to that particular portion. Thank you. So now this goes into the pathophysiology now of the congestive heart failure. As we can see there now, I've talked about preload and the afterload as part of our earlier explanation that I gave onto us there. And I told us about what vasoconstriction does to vessel, how the lumen is reduced. And then when the lumen is reduced, blood cannot flow very well. Now, this is actually a failing.
I can't hear you. Probably your network.
Yes, my network went off in a few seconds. Let's go to the pathophysiology now. Now, with reduced stroke volume, there's increased sympathetic tone, which means about vasoconstriction of the vessel of the vessel. And once that is done, with increased sympathetic tone, the heart rate is actually going to increase. Once there's vasoconstriction, the vasoconstriction will cause increase in the.
Oh, we cannot hear you since your network.
Afterload, and the increased afterload will be for the heart, and this greatly to be stable. Are you hearing me now?
No, sir, I think you have to go over it
Are
again,
you
sir.
hearing
Your
me
network
now?
is. We can hear you. I say you have to go over it again. The network really disturbed your explanation.
It's okay. Let me go over it again. You know, I talked about we gave earlier on. From here, the increased afterload and the increased preload. What causes each of them is this: when there is decreased stroke volume, there's increased sodium and water retention, and once that happens, it increases the preload, and that increases the stretching that has to be done to be able to cause filling at the ventricle. With that happening now, there will be increased pulmonary congestion. And that's why you see presentations like cough, increased respiratory rate, dyspnea that I talked about, and frotis sputum. And that's on its own, this presentation in pathophysiology circle of it, you saw why physiotherapy is going to come in with all this presentation as a sort of increased preload. The cough alone is a serious issue of intervention. Increased respiratory rate, serious issue of intervention. Dyspnea is serious issue of intervention. And frotis sputum is serious issue of intervention. And once that happens, this increased pulmonary congestion happens, there will be peripheral edema. like the jugular distension, the venous distension I told you about there, that I told you located close to the sternocleidomastoid. When you touch that aspect of your neck, you see it becoming gouge out like that. That's what they call jugular distension. Now that has to do with the increased preload. Let's go to increased afterload. The same decreased stroke volume, it can cause it will lead to increase in sympathetic tone. It will trigger up a cascade. Once that happens, the heart rate is going to increase. The same increased sympathetic tone leads to vasoconstriction. Once there's vasoconstriction, it tries to, of course, increase the venous return, which will lead to increased reload. But we are not going that circle for now. I'm just linking it to the increased preload. But the circle we are going into now is the circle of the increased afterload. The increased afterload will going to cause increased work of the heart, increased cardiac working. And increased cardiac working now will cause a serious decrease in the stroke volume again. And once there is decrease in the stroke volume, there is decrease in tissue perfusion. And that's why you see the patient now presenting with confusion, angina, palpitation, fatigue, decreased urinary output. And that is the explanation behind the pathophysiology of cardiac failure in the two instances. One has to have explained it in terms of the increased preload. I've explained it in terms of increased afterload, but all of them are traceable to the decreased stroke volume. Once there is increased preload, what you have is pulmonary congestion. When there is increased afterload, what you have is the increased work of the heart, decreased stroke volume, leading to decreased tissue perfusion. That is what really happens in those instances. Now, let's look at the complications of heart failure. From what I've discussed with us, you will see that complications are obvious. I will just pick this one out and explain it further. Now, breathing difficulties is going to be there because of the fluid buildup in and around the lung. Don't forget that blood cannot be pushed out from the ventricle to the lung. So there is so there's going to be building difficulty. And don't forget the issue of positioning I told us about. Supine, not it. Complete supine is not it. Fowler is more like it. And that Fowler is not more than, it's something like raising the head of the bed so that the patient can be able to be a bit more comfortable. Then other complications would be like kidney or renal damage. I've explained that to us now because of the vascularization of that place is so much that it receives over 20 to 25% of blood. So once there is a reduced perfusion, of course, you know that close structure is supplying is going to be affected. Then malnutrition there, loss of appetite, traceable to indigestion. The other heart condition begin to happen, irregular heartbeat, sudden cardiac arrest, and also pulmonary hypertension can happen. Now, there are what we call stages of heart failure. Stages of heart failure. And we look at the American Cardiac Society, we look at the American Heart Society Association classification now to be able to explain that to us. Of course, I would want you to be able to pick out this. It's something you can pick out, get one of the slides out and print it out. You begin to use it to monitor in your assessment, in the evaluation and re-evaluation, in outcome measure management of the patient. Now, when we go into this ACC and AHA classification of heart failure, we begin to look at them one after the other, stage A, stage B, stage C, stage D. I want you to please follow this. It is different from New York heart classification. We are going to see that one later on. This one is ACC AHA classification, and it has to do with A to D classification of it. I want you within few moments, pause and see what I'm talking about, and I will launch into it very soon. Stage A has to do with at risk of heart failure. In this instance, there's no symptom. There's no structural heart disease or evidence of elevated biomarkers for the patient, but the risk factors are beginning to be present in that patient. Now, stage B has to do with what we call pre-heart failure. Pre-heart failure. And when patients begin to have this, the patient have no signs or symptoms of heart failure. 2, almost resembling stage A, but the difference is that it is a different stage entirely. This one has structural heart disease compared to the other one that does not have structural heart disease. So pick that. Stage A, no symptom, no structural heart disease. Stage B, they have no signs or symptoms of it, but they have structural heart disease beginning to come up. And then there's also evidence of elevated filling pressure. There's persistent elevated cardio biomarkers in the tests that they are done. In the absence of other reasons for elevated biomarkers, of course, you have to rule out other reasons like chronic kidney disease or myocarditis. So that classifies the patient to be in stage B. Stage C has to do with patient with structural heart disease and current or past history of heart failure, while stage D has to do with patient with refractory symptoms which interfere with their daily life or recurrent hospitalization. You can have to look at the admission, readmission cycle again. Now, I'm going to ask you a question to test whether you have a good understanding of what I've just talked about in the last few seconds. A patient that is going through the cycle of admission and readmission most likely will be in what stage?
Stage D.
Stage what?
D.
Stage what?
D.
Okay. Again, who else want to try? I want many people to try.
Stage D.
Okay, another
I
person
said
to try.
Stage D.
Yes, I heard you. Another person to try.
D.
Okay, let me ask you. Well, you are right. D, you are right. Now, let me ask you another question with respect to this. Presented with no symptom and there is no evidence of structural heart disease. Which stage is that?
Stage A. Stage A.
Stage A.
Thank you very much. Now, a patient is presented with past history of heart failure. Past history of heart failure.
You can't hear you again.
Okay, network.
Stage C. C. Stage C. Stage C.
Stage C.
Right. Now, a patient is presented with evidence of elevated filling pressure with no clinical signs.
Stage V. B.
Fine. So that means we have
So your network.
what I'm
Your
talking
network.
about, isn't it? Okay, let me hold on. I said that means now we have good understanding of what I'm talking about ACC and AHF.
Yes, sir. Yes, sir. We have it. Thank you, sir.
Now I'm going to finally ask you a question. There's issue of interference with daily activities of living, ADL. What classification will you put for the patient?
D. Stage D.
Thank you very much. Thank you.
D. Stage D.
That's good. Now, I've tried to condense this into a simpler form again. Still talking about
Yes,
A, B, C, D classification. A, no symptom, heart function is normal. B, heart function has decreased but no symptom present. Stage C, symptoms appear such as shortness of breath, heart function is decreased. Stage D, heart function has significantly weakened. Let me throw up an imaginary test done by a patient. Now, a patient was examined and the patient began to show signs of shortness of breath, but no significant weakened heart. What stage will that patient be?
A, shortness of
Come
breath, but
again
no
with the
weakened
question.
heart.
Okay,
B.
I said a patient, imaginary patient anyway, is presented with shortness of breath, but there is no significantly weakened heart.
Stage C.
Okay, thank you. I wanted to actually test the understanding of C and D. You are right.
D.
What can you pick out from that question? What is significant about that question?
Said weakened heart, but the person is breathless.
Yeah, the
Significantly
person
weak.
is
The audio is
breathless,
badly
but the
present.
person does not have significantly weakened heart.
Weakened
That's
heart.
what differentiates that person from stage D. I'm happy that we have been able to pick that. Now, the next slide I'm going to give on to Ross now. explain what I've said earlier on, but he puts the ACC-AHA heart failure stage A to D on one side and the New York Heart Classification of Function on the other side. ACC is the American College of Cardiology. AHA is the American Heart Association, in case you want to understand what those things actually stand for. So that's the class. When you talk about A to D staging, that is ACC-AHA. When you talk about 1 to 4, that is New York Heart Association classification. Let me stress it again. ACC-AHA talks about staging, whereas NHHA talks about classification, and that one has to do with numbering. What that deal with numbering is NHHA, New York Heart Association. The one that deal with lettering, staging, it is ACC-AHA. Now, because I've explained ACC-AHA out, let me now go out ahead and explain NHHA. That is New York Heart Association. Classification 1, there is no symptom, it's asymptomatic. Now, classification 2 is symptomatic with moderate exertion. Classification 3. Okay, it's my network. Let me hold on for some few seconds. Are you hearing me now?
Yes, sir. We can hear you, sir. Yes, sir.
It's okay. I was trying to say that I put this in a table together. I was trying to distinguish between ACHA staging and NHA classification. When you see staging, it has to do with ACC-AHA method. Then when you see classification in terms of numbering, it has to do with New York Heart Association. That's the difference I'm going to do. I said because I've explained ACC-AHA, let me go into NHHA and explain now, which has to do with functional classification. And classification 1 there, it means the patient is asymptomatic. Classification 2 is the patient is symptomatic with moderate exertion. Classification 3 is a patient is symptomatic with minimal exertion. Classification 4 is a patient is symptomatic at rest. Now, I'm going to ask you a question now to test your understanding of what I've just said. But before I ask you a question, do you understand the New York Heart Association classification now?
Yes, sir. 70%.
No, sir.
Can I ask you a question now?
Please, you can come on.
Okay, let me explain again. Okay, let me explain again. New York Heart Association classification. Once again, to distinguish it from the other one, that other one has to do with staging. This one has to do with classification, one after the other. It has to do with symptom presentation. Now, it has to do with breathlessness or no breathlessness, like I explained about some 50 minutes ago. Now, class 1 is asymptomatic. Class 2 and class 3, class 4, 2 to 4, they are symptomatic. But the difference in class 2, 3, and 4 is that class 4 is symptomatic at rest, even when doing nothing. Class 3 is symptomatic with minimal exertion. Class 2 is symptomatic with moderate exertion. So you can even further group NHA into 2. Symptomatic, asymptomatic. Asymptomatic is class 1. Symptomatic is from 2 to 4. Now, when you want to now distinguish the symptomatic classification in New York Heart classification, it has to do with the level of exertion. If the symptom comes with moderate exertion in class 2, if it comes with minimal exertion in class 3, if it comes with at rest, is class 4. Do we understand now?
Yes, sir. Yes, sir.
It's okay. Now, let me ask you a question. Hypothetical presentation, but you answer me. A patient after assessment has been shown and all tests examined, has been shown to have structural heart disease with previous heart failure and is having symptoms even at rest. A patient after assessment
Your network is fluctuating.
has been shown to have structural heart disease, is now presented with an NHA. Please go ahead and answer me.
Stage 4.
Symptomatic.
Classify it under the two classifications now.
It's type 1. Symptomatic.
ACC stage D and NYHA class. I didn't get the case in your next.
It is stage 4, symptomatic at rest.
You are right for that one. What of the ACC class staging?
C. Structural heart disease with current heart failure symptoms.
So the patient is symptomatic, so at rest.
That. What
So
stage
it's
is
type
that?
Stage 1.
Yes.
Stage 1, sir.
So symptomatic at rest is 4. The first the answer is right. 4. Symptomatic at rest is 4. Yes, you are right.
Yes.
Now, somebody has also answered. I said you should do classification to order the staging. What stage will it be? I know somebody has answered. What stage? The answer it again.
Stage C type 4.
That for yourself. Stage C type 4. So you are now assuring me now that whatever the question I pose to you, you can do your staging, you can do your classification. Yes or no?
Yes, sir.
Yeah, that's great.
So I can continue, isn't it?
Yes, sir. Go on, sir.
Can I continue or any question?
Continue, sir.
Now, I've tried to explain this before, but I want to go further, give me some further explanation about left ventricular ejection fraction. You know, I told you it could be with reduced, it could be with preserved. Now, I want you to look at these 4 listing out. I look at the heart failure in terms of reduced, I look at it in terms of mildly reduced, I look at in terms of it as preserved, I look at it with improved ejection fraction ratio. And this can also be used to monitor the patient prior to treatment, during treatment, and after treatment. Now, with reduced ejection fraction ratio, of course, we will agree with what I've said earlier on. You see R there. That small R in between indicates reduced. Of course, I've told you EF is ejection fraction, the pumping power. That is it, which is always recorded with a percentage. It is either less or equal to
Your network.
40%. Now, when it's mildly reduced, I'm going to ask you some questions so without some classification. Now, when the patient has preserved ejection fraction ratio, which is the P that you see there, is greater than 50%, there's evidence of heart failure. The elevated cardiac biomarkers are there. Cardiac biomarkers are there.
Your network is
Elevated feeling pressure too. Okay, let me hold on. Are you hearing me now? Are you hearing me now?
Yes, sir.
Yes,
Okay. I want you to take note of these 4 things concerning ejection fraction ratio. I know I've explained to us before 3 of them. That is the reduced, the preserved, and then the middle range. I've explained that to you before. Now, I want to also further buttress that to thicken understanding concerning this. Heart failure will reduce ejection fraction. By now, you should still be able to recollect that I said that it's less than 40%. When it's mildly reduced, it is between 41 to 49%. In that instant, the patient begins to have elevated biomarkers, evidence of it, and elevated feeling pressure. Now, in preserved ejection fraction, the ejection fraction is greater than 50%, and there is evidence of heart failure. There's elevated biomarkers and elevated feeling pressure. Then when there is improved ejection fraction ratio with heart failure, in that instant, we see previously documented left ventricular failure less than 40%. These are the points I want you to take note of. The range determines whether there is reduced ejection fraction, whether there is preserved one, whether there is middle range. Do you get that? I'm not hearing that person network. I'm not hearing you. What did you say? Are you asking a question? Can I continue?
Yes, sir. Continue, sir.
Okay, thank you. Now, I've talked about New York Heart classification. We shouldn't have problem about this again. Like I told you, print this out. It's going to help you. It's used for patients with symptoms of heart functions. Once they are a symptom, you go to this aspect. Onset is more than ordinary. Are you hearing me?
Yes, sir.
Are you hearing me?
We didn't get the previous slide, sir. Previous.
Fine. I was trying to further buttress the New York Heart classification.
Yes, sir.
About class 1 to 4. I've told us that class 4, there is symptom at rest. This particular one further distinguish class 3 to A and B. A is no dyspnea at rest. 3B is recent onset of dyspnea at rest. That's an advanced form of this classification. If you want to go further on it, it still talks about symptom or no symptom. Now, I want to go into major criteria and minor criteria for heart failure. Major criteria are acute pulmonary edema. I've explained the pathophysiology behind that. Cardiomegaly, hepatojugular reflex, next vein distension, pulmonary race when you do your auscultation, and the third heart sound. You remember the lub-dub-dub, 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 lub-dub,
Yes.
S1, S2. But when you have lub-dub-dub, that is S3. Those are major criteria. Then for minor criteria, there is edema, there is dyspnea on exertion, there is hepatomegaly, there is night cough, there's pleural effusion, and then there's a heart rate that is greater than 120 per beat per minute. Then this has to do with a correlation between the ACG and New York Heart classification. Now, stage A, when you bring it to New York Heart classification, you remember that I was asking you a question, and I asked you to do staging, to do classification. Now, if you want to now condense it into a table, comparing the two together, in case I ask you a question, of course, which I'm going to do after this again.
We are not hearing you.
Okay, are you hearing me now?
Yes.
Hello?
Yes, we can, sir. Can hear you, sir.
Okay. I told you that I asked you a question earlier on, and that question has to do with, I asked you to do staging, to also do classification based on New York. Now, this portion I'm entering to now is to bring them together, to further deepen the understanding, and I'm going to ask you a question in between, to correlate the two of them, the staging and the classification. When there is stage A, when there's high risk of developing heart failure, but there's no identified structural abnormality, there is no direct application on New York Heart Classification. Now, but when you get to stage B, when there's structural heart disease that is strongly associated with developing heart failure, but there's still no signs and symptoms, you can get it to liken it to stage 1 of New York Heart Classification. In this instance, there's no limitation to physical activity. The ordinary physical activities of daily living is not interfered with per se in that particular patient. Now, when you get to stage C again, you can still liken it to stage 1. You can liken it to classification 1 on New York, even though there is symptom which is associated with underlying heart disease. And when you want to describe, there's no limitation in physical activity at all, or ordinary activity. And then it does not cause fatigue for the patient. There's no palpation. There's no dyspnea. Then there's also possibility of likening to stage classification 2 on New York. In that instance, when the patient begins to have slight limitation.
It's just that I think it's from the slide in a book.
The network again, you are not hearing me?
Yeah.
Are you hearing me?
We can hear you perfectly.
It's okay.
We can hear you now.
Let me pick this up. I told you what I'm doing now is to put staging, put it aside the classification of New York. I hope you got that.
Yes.
Did you get that?
Yes,
Did you get
sir.
that? Now, I am comparing now stage C to the New York now. I told you 2 possibilities there. It can be compared to stage 1 and also compared to stage 2. Now, compared to stage 1. Are you hearing me? Somebody is talking? Are you hearing me?
Yes, sir. He has muted himself.
We can hear you, sir.
Thank you so much. We move on. We are comparing ACC with New York now. We are on stage C. Depending, it could be likened to classification 1 or classification 2. What distinguishes it there is that it will be stage C can be likened to classification 1 if there is no limitation in physical activity. But it can be likened to classification 2 if there is slight limitation in physical activity. It depends on the presentation. It depends on if in a hypothetical case when question is pushed across to you, it depends on whether there is limitation or there is no limitation. I'm going to ask you a question now. The patient have associated underlying structural disease, but there seems to be no physical activity limitation. Compare and contrast the two. Will it be class 1 or class 2?
Class 1.
Class 1.
Class what? Class
1.
1. Thank you very much. You got it. We move on.
Yes.
We move on. Now, still likening stage C now. If there's marked limitation, that will be class 3. Then, if there is symptom at rest, that will be class 4. Then for stage D is likely to class 4. It's likely to class 4 because, of course, you know, we have said earlier on that in stage C, there is advanced structural disease. And you expect, of course, there will be symptom at rest. Where you possibly may have challenge is in stage C, whether it correlates with class 1 or class 2, class 3 or class 4. But you should not actually have challenge if you understand the presentation of the patient very well. Is that clear to us? Is that clear to us? Is that clear to us?
Yes.
Yes, sir. Yes, sir.
So if I pick you up on stage C now, you can find your footing on New York, isn't it?
Sure, sir. Sure, sir.
Okay, can I ask you a question?
Go ahead, sir.
Yes.
Okay. Structural heart disease with symptom at rest.
It's stage
Answer.
4.
Stage 4.
Classification 4. Classification 4.
Classification 4, stage C. Is it? I want you to put stage with it. Stage C, classification 4, isn't it?
Sir.
Yes, sir.
Okay. Can I go ahead and ask another one?
Yes, sir.
The there's underlying structural disease. But you see the man jumping, the man's office is on the 4th floor, and he's still able to go and do all his work without using lift at all in the office.
Stage 1 plus, sorry, stage C.
Sir, could you repeat the question?
Stage
Okay,
C.
I said the man, there's evidence of structural disease, but the man's office is located on the 4th floor. Even though they have lift facility in that office, he doesn't use the lift facility. Classified.
Stage C
Class
plus
1.
Let's clap for ourselves. Now, possible relevant investigations now: blood tests, radiographs, echo, Doppler ultrasound, abdominal pelvic ultrasound is there. Now, let's look at our differential diagnosis now. Disease that may present with clinical features of volume overload of dyspnea are in the differential for heart failure. And those diseases include renal failure, acute respiratory distress syndrome, cirrhosis, pulmonary fibrosis, nephrotic syndrome, and pulmonary embolism. Of course, I won't have to go too much into this again. I've explained this out to us about the staging of it one way or the other. Of course, okay, let me go through it because of the issue of treatment. Now, I'm using this HCC and NHA, bringing it back again in terms of the goal of treatment to improve the symptom and the quality of life in order to decrease hospitalization. Don't forget, we are trying to say through this workshop today, we are looking at the admission and the readmission cycle. And now all aspects of medics come into the management of the patient to be able to mitigate the effect of it, and to improve the quality of life of the patient. Now, the stage of the patient determines a lot of things. It's beyond the issue of classification for you to know in diagnostics for the patient, to know whether it's with reduced ejection fraction or whether it's not with reduced ejection fraction, whether it's stage A or stage B. It also, those things are applicable in the management of the patient. Now, in patients presented for stage A who are at risk of heart failure, that we said, that's patients with hypertension, the guideline directed by medical therapy is adopted for the management of the hypertension of such patient. And the patients that are at risk of heart failure due to exposure to cardiotoxic medications, they should be managed with multidisciplinary approach. What we are trying to do in this instance is that those stages direct the management of the patient. You have to understand the patient stage before the management can be understood. The way stage A is going to be managed is different from the way stage B is going to be managed, is different from the way stage C is going to be managed, and the way stage D is going to be managed. That's what I'm trying to explain out in all this. Of course, let me stay put on stage D now. For stage G, which is all of us will agree that is advanced stage of heart failure that require frequent hospitalization, referral to an heart failure specialist is indicated. Referral to heart failure specialist is indicated, and very, very important. And the patient may be on mechanical cardiac support, very important. The patient is for highly selected, the treatment is for highly selected patients. There may be cardiac transplants indicated in some instances to be able to improve survival and quality of life. And the goals of care actually is decided by shared decision making, which is going to include considering the comorbidity condition of the patient, the frailty of the patient, the socioeconomic support of the patient, the palliative care comes in there, which should be offered and indicated as part of shared decision making. You see, where the more the patient climbs the ladder in staging, the more the intensity of management. And that's why you see here now, such patient may also now be under critical care. they have been referred to specialists, heart failure specialists. They are managed in a set of team, and decision is taken in a shared pattern, and a lot of things is taken into consideration in the patient. The patient may be selected for interventions like cardiac transplant, but this may be indicated in patient issue of maybe there is a survival issue is considered, quality of life of patient is considered, and also further consideration is given to the comorbidity presentation of the patient, other condition the patient may have, the frailty of the condition of the patient, and also some other socio-economic factor involved. But we need to take note of the fact that palliative care is part of this indication. Now, the slide that you have before you here has to do with the definition and the suggested intervention for patients with heart failure at different stages. Like I told you, each of the stage have its own intervention. This will show better to you. Now, in stage A, there, which is without structural and cardiac failure, without any heart function, the intervention, risk factor modification by healthy lifestyle and medication is indicated here. Now in stage A and stage B. Now, you just modify the risk factors. So whether it's smoking, the person is given to inactivity, the person is taking too much salty food, the person's life habit is the one that has predisposed to the, you take care of the lifestyle of the patient. And when we understand this staging very well, we now see that we too as physiotherapists, we come in right from stage A to, because activity modification, if somebody has been given to sedentariness, or the person is given to, if the person has obesity, you come in to manage all those things. It will help the patient in that instance. For that, also determine the medication the patient is going to go in. Of course, then we go to stage C, which some symptoms are beginning to come in. Then interventions in medications and surgeries come in, and also we too as physiotherapists come into the management of the patient. Don't forget, like I said earlier on, the stage D, which is the advanced stage of it, requires some intensity of intervention, which may need some mechanical circulatory support, and then also in some instances cardiac transplantation, and also palliative care as may be needed in some instances. And these are the drugs of use in the management of this condition. We call it ABCD approach. The lisinopril, which lowers the blood pressure, the beta blockers too, which lowers the heart rate and the blood pressure, the calcium blockers too, which lowers the blood pressure and the heart rate, the likes of nifedipine, then the digoxin, which lowers the heart rate, the vasodilators, then the diuretics. These are the range of drugs that are used. To further explain further, the diuretics, the work they are used is to eliminate the fluid. You know, we talked about the accumulation of fluid here because of inappropriate of perfusion and inappropriate of reloading of the heart back. Then, so the diuretics is going to help there. The beta blockers will help to reduce the heart rate. Don't forget, we said that the heart rate is heightened there because of the struggle to keep the heart at work. So the beta blockers works there. Also, the digitalis will help to increase the strength of the heart contraction. Don't forget that what actually predisposes the patient to this is that a lot of cardiac structural abnormalities that develop over time, and the strength of the muscle is not there to carry. So digitalis are help in that respect. So now in severe cases, surgical intervention can be indicated, and that's why you see us coming into as part of the pre-op and post-op intervention in the procedures like CABGD, that's the coronary artery bypass grafting, heart valve repair and replacement. You see it, such a procedure are done, and physiotherapy will be indicated in those instances. Having done extensively, laying the foundation into the cardiovascular system, connecting it with cardiovascular disorders, with particular emphasis on congestive heart failure. I will be going now into physiotherapy management of congestive heart failure. But before I go into that, we are going to go into break now. We are going to come back at 1:45. Please go and take water, stretch your legs, and then please ensure that you also get prepared for a very, very important segment of this workshop today, physiotherapy treatment of congestive heart failure. Thank you very much. At 1:45, 12:45 p.m. Nigeria time, we'll be back. Thank you.
Thank you, sir.
Know it was possible to have the documents to reflect on as you are teaching.
Yes, you are going to have it. You are going to have it.
I do hope that the workshop is being recorded. Some of us are being on and off, please. The recording part would be wonderful. Okay,
Yeah,
okay.
it's recorded. With the previous ones, we've been getting the recording.
Oh, thank you very much. Thank you very much.
We are welcome back. Are we online? Are we online?
Yes, we are, sir.
We are.
We are online, though.
Back. How was your break?
Yes, sir. Online, they ask.
Now we do for your good work, sir.
Thank you so much. So we are going to continue again now. Is my slide on the screen?
No,
is
sir.
my slide on
It's
the
not,
screen?
No, the slide is not on the screen.
It's only the background.
Okay.
It's only the background.
Only the desktop background.
It's okay. Is it on the screen now?
Yes, it has
It's on the screen.
Okay. Well, welcome back.
Yes, sir.
So we are coming to the close of our workshop this afternoon today, as we consider the physiotherapy treatment of this condition. We actually work with the other team members to be able to implement treatment guidelines for these patients. And our intervention is aimed to improve the activity. Of course, you can see the circle in heart failure. And you can also get to understand and appreciate this very well through the staging we have done through ACC and HAA, and the classification we have done through the New York Heart Association classification. You will probably be able, or by now, you've understood what will necessitate our intervention. So, in implementing treatment guidelines to treat this patient, collaboratively working with the other healthcare team members, we are going to aim to improve the activity of the patient. We are going to help them improve participation, which of course you know that is a serious issue for consideration in the rehabilitation 2030 that we are really promoting now, and we want to meet the target. I want to see how the patient can still get participated in his or her life as now. Then we look at the quality of classification we have done, understanding the pathophysiology of the patient and the the network. The network. I'm back now. I hope you are hearing me now. Are you hearing me now?
Yes, sir. We can hear you.
Are you hearing me now?
Yes, sir.
Yes, we can hear you.
So I was telling you that in working collaboratively with the other team members, we would ensure that we implement treatment guidelines to be able to attend to and improve the activity of the patient, the participation of the patient, the quality of life in the patient presented with heart failure, and also to reduce the incidence of heart failure related readmission for the patient. And we actually play a fundamental role in the comprehensive examination of the patient, taking into consideration a good understanding of the pathophysiology of the condition, as enumerated and extensively discussed in this workshop today. We go ahead to evaluate the patient, and then we go to the extent of planning the treatment of intervention in heart failure, which of course you'll be able to appreciate from the previous slide that I've done, and also the medical management of
You are off, sir.
that. I hope you have appreciated. Are we online? Class, are we together?
Yes, sir.
Yes, we are.
It's okay. So we go from examination to evaluation and the treatment. I was trying to say that on treatment, it has to do with stage of the treatment. And of course, the treatment with heart failure continues throughout the continuum of so we continue to get relevance here to of the patient and also to the band on the effectiveness of our rehabilitation interventions for patients that are having heart failure. And of course, we also know that evidence continues to come up from time to time supporting the efficacy of intervention of physiotherapies in the management of this condition. But if you want to summarize on a whole lot, before I go into the details, you will see that intervention actually include exercise, includes things like aerobic exercise, inspiratory muscle training, electrical stimulation, behavior modification strategies for the patient. And our intervention will aim to positively influence the functional capacity of the patient, of the patient, both muscular, the cardiac strength of the patient too, of the patient. When this is done, it's going to decrease hospital readmission of the patient. And then this goes back to now to almost about picture I showed to you the other time. I show it on large scale. I'm going to project it further now for you to see. Let me go into for me. Okay, now look at the classification one after the other. This is a classification 1, 2, 3, 4 for this patient. When you use New York Heart classification, it talks about what we can do can we see slide 118? Can we see this slide?
Yes, sir.
Are we together, class? It's okay. Yes, now, I was talking about the treatment, and I told us that the treatment derives from presentation 1. The treatment also derives from staging, according to that ACCAHA. The treatment also derives from the classification based on New York Heart Association classification. And I said that I started picking them one after the other. Patients that we have identified without discomfort for that patient includes things like jogging, climbing stairs. Don't forget what I said. A network. I'm back with me. Are we together?
No, network. Oh.
Network, ba? Okay. If you are hearing me, please say yes so that I can now.
No.
It's on and off, so we can't hear you well.
Slide 118.
We can't hear you. We can't hear you.
I will repeat slide 118, but I want to. Now.
We're not hearing you. The network is still bad.
Are you hearing me?
Not at all, sir. Not at all, sir.
Are you hearing me?
Yes,
You're
we
clear
can
now,
hear you
sir.
now, sir.
You're clear now, sir.
We cannot hear you again, sir. So I'm going to drop a quick MET chat on the group, in case anybody wants it.
I'm back. I'm sure you don't have my slide again. Let me reshare, please. Please, are you seeing my slide now?
Yes, we can see it, sir.
Sorry, network cut off the sharing. But I hope you are hearing me now.
Clear, sir.
Yes, sir, we can hear you.
I told you in the history taking, we have been able to gather a lot of facts from the patient, his presentation and co. We have done our examination and we have been able to now classify the patient either through staging of AHA or ACC and then either through the New York Heart classification. Now, depending on what we pick up there, depending on the stage of the patient, depending on the classification, just like I emphasized in the medical intervention, the same thing is going to happen in a physiotherapy management of the patient. Now, for class 1 of such patients, if we present with class 1 New York Heart classification, our physical activity that can be done, our prescription that can be done without any discomfort for the patient must be greater than 7 metabolic equivalent of task. And that has to do with things like jogging at like maybe 8 km/h, climbing stairs rapidly in cold weather, climbing stairs while carrying 11-kilogram objects, and playing basketball and squash. For people presenting with class 1, they can still be given such prescription without any challenge for them, and it's going to be beneficial for such patients. Now, for patients or individuals that have been classified and diagnosed to be with class 2 under New York Heart classification, their operation of work, their operation of activity will be between 5 to 7 metabolic equivalent of task, METs. That's what MET stands for, metabolic equivalent of task. That means the energy quantification that has been attached to each particular work. Now, for those people in class 2, such things that can be prescribed for them, they will do without unnecessary discomfort, and like walking at 6 km/h at ground level. They can climb more than one flight at normal pace, or they have non-stop sexual intercourse. And that introduces another aspect to our days. As part of the quality of life of our patient, they may be asking, can I still continue with my conjugal relationship based on my presentation? That has to be a function of the stage of the presentation. As we know, conjugal function is related to the functionality of the body, the exercise tolerance of the individual. So if somebody is still with classification 2, he can still go.
You're breaking up, sir.
Without much challenge. Now, class are up network. I'm back now. I hope you are hearing me. Are you hearing me?
Yes, sir, we are.
Yes, sir.
Cut me off again. I was speaking on class 3. If the patient, from all the assessment you have done, the classification you have done, the staging you have done, and the patient happen to fall under class 3, every activity that will be recommended for that patient will be between 2 to 5 metabolic equivalent of tasks. and the patient will be walking at like 4 kilometers per hour on level ground. The patient can do climbing, the patient can do showering, the patient can dress without stopping or without stopping, and the patient can also play golf. Now, for patient now that is now at classification 4, you know that is another dimension. If you fly your mind back to what classification has to do with, is the patient is becoming symptomatic even at rest. So you see that the high tax of the action going to. So the patient now for class 4 will operate at less than 2 metabolic equivalent of task, having symptoms when carrying out any physical activity or even at rest. That's what happened in that case. So you have to moderate what that patient will do so that there will not be exacerbation. And apart from prescription, you have to now go into education. Say, you are, because of your presentation now, Mr. A, because of your presentation now, Mr. C, these are the kind of things you can do that will not make you to be breathless. These are the kind of thing you can do that will not unnecessarily sap you or drain you or render you fatigued or make you maybe for your symptom to be exacerbated. You go into that education and you now prescribe and you now monitor for that patient. Don't forget, the higher the score on the classification, the less the metabolic equivalent of task. Do you understand it? Can I go on?
Yes, sir. So I wanted to ask relative to ADL because it looks
Yes.
like most of the ADL seem to be between 2 and 5. That is independent task for someone to at least manage with inside the house. But for most people who will be able to manage well outside their houses, they will probably be anywhere between 5 and 7 or higher, I think.
No, where you have a bit of point, but not completely. The
Okay,
issue
sir.
is that you see, there's also a technique they call pacing technique.
Yes,
The
sir.
pacing technique is about spacing out the activity that the patient will do. The patient will still be able to carry out of course, there will be activity modification. I recognize that. But the patient now, even the activity that he has to do after their modification will now have to be broke. Part of the modification is that it has to be broken into piecemeal. Just like somebody that is supposed to finish a bowl of food. But the patient, the individual now has to now take that food maybe about 4 times to finish. That's what the patient is all about. They now say, okay, for your activity for the day, let me have an understanding of what to do. Now say, okay, do this at this particular point in time. You will now do timetable for activity. Then at that particular another point in time, you do it. The essence of it is that the person will not be unnecessarily drained. But don't forget, the symptom of breathlessness and fatigue increases with classification. For people that are still between 1 and 2, they will be able to still reasonably do something for themselves very well. Is that understood?
Yes, I completely understand now. If I was
Thank
to
you.
rephrase my if I
Pardon?
was to rephrase now based on classification for someone on
I
a
should give
level,
you what?
if I was to rephrase myself based on the
Okay.
classification, that
Yes.
means for someone on like level 4 who is breathless at um rest, symptomatic at rest, the target will even be to at least achieve MET2, but you can pace that person based on MET2, maybe it's like sitting up in bed.
Yes.
Then for
Simple free active exercises.
exactly. And
Yes,
then
simple
so
free active
basically
exercises.
you always
You don't praise the person on something strenuously exertive.
yes, sir. Based on maybe
Yes.
by because we're doing I think level and class. I can't remember again. Where we
Yes.
have level 1 to 4.
Staging and class.
Staging and class. So it means
Yes.
that if we're doing this MET will probably be more related to the state. I'm sorry, the 1, 2, 3, 4. I'm sorry, I don't know which one is class. I just know the
No, it's
1, 2, 3,
okay.
4 and A
I
to
want you to
D.
be free to talk so that I can correct. Have you
Yes,
finished
sir.
so that I can correct?
Yes, sir. So I know A to D is based on the level of damage, and class level 1 to 4 is based on the level of activity tolerance. So when we're doing MET targets for patients, even if the person at rest is on certain levels, we know that the target will now be maybe an MET class that is higher. And then we'll just be pacing the person. At least the person knows that they have a certain baseline based on their class, that's their medical class. Sorry, I just saw the screen. The class is in front of me. Based on their medical class, and then maybe their target can be the class that is above, but they will have to pace themselves to achieve it.
Yes. And let me also let's say this, even though I'm using this New Yorker classification to explain this out, I want to correlate it with ACC and AHA. Now, for somebody that's already on stage D, it's a question I'm going to push on to you now. What do you think will be the prescription for that person? Stage D on ACC, AHA.
Well, I think in stage D, you have to first know the person's class, but you expect that the person will likely be about a class 4.
No, from your, no, I've done correlation for you. Classification
Okay, yes, sir.
with staging. Stage
Yes,
D,
sir.
you know what it translates to in class.
Yes, sir.
If you remember, what does it translate to in class?
A stage D in class will be a class 4, symptomatic at rest.
That's why I want you to fly your mind back onto our discussion, because all of them are interwoven, they are related. So what will be the prescription?
Sitting when able and having support with activity.
Fine. Activities, free active exercises, monitor the patient, it is going to help. Is that okay?
Okay,
now,
sir.
we move on. Now, I hope all of us are together. Now, what we want to do now is that we want to tag signs and symptoms with treatment zone and the recommendation of the patient. So 3 things in one now. We want to look at the zone color. They want to look at the sign and kind of intervention that we can do as physiotherapists. Now, when you look at green zone, the green zone, of course, we know what green is, always like a comfortable zone. In that instant, there is no shortness of breath, no swelling, no weight gain, no chest pain, no decrease in the activity, and the patient is able to maintain his level of activity. There's no decrease in level of activity at all. In that instant, the recommendation by the physiotherapist will be to continue activity and therapy as tolerated by the individual. That is the green zone. Now, from the green zone, we go to the yellow zone. In the yellow zone, what is expected as times of symptoms, signs and symptoms of the patient is there will be weight gain of about 2 to 3 pounds within 24 hours. There will also be increase in cough. There will be peripheral edema. There will be increased distal extremity swelling. There will be increase in shortness of breath with activity. Then there will be autopnea, increase in the number of pillows needed for the support of the patient. Now, what do we expect? Symptoms may indicate an adjustment in medication and therefore warrant communication with the physician in that instance. When they present that, of course, in our triaging referral, so I hope we are doing your follow-up. Again, if the person is not doing the follow-up, you will refer the patient to do the follow-up. And in that instance, you drop on the dosage of intervention because of this further presentation. And of course, the protocol there now will attend to the issue of the cough of the patient. The protocol there too now will also attend to the issue of breathlessness, and the protocol must be structured in such a way that the activity that will be given to the patient will not lead to further increase in the shortness of the patient. And also, the protocol will include the positioning of the patient. Don't forget what I said earlier on. Fowler position is well acceptable and beneficial to them. And in this system, we said that the number of pillow support will increase for that patient. So we are transited from green zone to yellow zone. We are going now to red zone, just like the traffic light that you see on the road. In the red zone, there's shortness of breath at rest, which there's unrelieved chest pain. There's when you do your auscultation for the patient, there's wheezing, and there's tightness of the chest. There's also weight gain or loss of more than 5 pounds in 3 days. Don't forget the previous one I said that like about 3 to 4 pounds within 24 hours. But this one is about 4 pounds, 5 pounds within 3 days. That would be like red zone, and there will be confusion. In that instance too, triaging with the physician that is managing the patient is there. If the patient is doing is not undergoing his medics, You need to discuss with the patient as part of the patient education. Tell him, please, have you been going on your treatment? He said, no. Please, you need to go back for your treatment for further follow-up. And if he's going on follow-up, what has your physician told you? And of course, the protocol that we're also going to administer in that case will take into consideration, will be such that will not due to exacerbation of the chest pain, will not lead to the exacerbation of the shortness of breathing, and then will take into the consideration that there is wheezing. Wheezing means the narrowing of the bronchos. So enough air is not actually even getting to the lung, and that also shows that the oxygenation process of the lung, of the blood that is brought into the right ventricle will not be full, and for it to be brought, that it will affect the perfusion of the patient too. So all the protocol that will be given to the patient will take this into consideration. This has to do with the red, yellow, green issue concerning the congestive heart failure. Do we understand this?
Yes.
Yes, sir.
Now, let me throw up some hypothetical question for you. A patient did not have weight gain and has been put on some physiotherapy intervention, free active exercises, and then some auto-assisted exercises. Which particular zone is that patient? Which particular zone is that patient?
Green zone.
Green zone. Thank you very much. The patient has weight gain of about 3 pounds within 24 hours and has some traces of shortness of breath. Which zone is that patient?
Red zone. Red zone.
It is the yellow zone.
Yellow zone. Yellow zone.
I deliberately hid it from you. Now, the patient had weight gain of about 5 pounds in 3 days and have increased shortness of breath and need a lot of pillow support for comfort with tightness of chest. Which zone is that?
The red zone.
Thank you very much. We move on now. I'm going to make some about 9 documents available for you. They will push it out across to you for your further reading, for you to check and cross-check here and there. This still explain further. Like when I started doing explanation of physiotherapy intervention, I brought it out, relating it to staging. I started relating it to classification, and some good questions actually came up, which I've tried to explain onto us. And then some of these 9 documents will be made available for you for formal reading and cross-check on it. I'm not going to visit all of them. I'm going to share some of them with you now so that you will see what it looks like. So just give me some few seconds. I will share with you now.
Sir, we are not hearing you. We can't hear you.
Yes, you're not hearing me. I'm trying to share some documents with you now. It is true you will not hear me for now. Let me try and pick that document for you. I'm coming. Fine. Are we together? Can we see my slide? Are we together? Are we together?
Yes, sir. Yes, sir.
Yes. Okay, please let me share with you now my slides. Now we go to, this has to do with sorry, I'm coming. Sorry. Now this has to do some prescription that we can give to our patients. I'm starting with the MIT and CT training for the patient that we can prescribe. Now with this, it's a bit of, it's not too clumsy for us to understand. We look at the intensity of operation of the exercise. We look at the frequency of it, and it has to do with studies. It's a evidence-based type of it, based on randomized controlled trial studies that have been done. The intensity for the moderate intensity approach is 70 to 80% maximum heart rates. And then it can be done at frequency of 3 times per week, and then a duration of 12 weeks. There is no adverse effect that is actually gotten for me. Let me go back to how you get your maximum heart rate. There's when you go to 220 minus age of the patient, of the client, that is going to give you the maximum heart rate of the patient. Now, the target heart rate is gotten for a percentage of that particular figure. Now, say you calculate, let's assume that the maximum patient of like 50 years, 220 minus 50, that is 170. For you to get this target heart rate of that patient, you are going to, for you to get 70% of it, you put 70 over 10 times 170. Whatever figure you get, it is the target heart rate for that 70%. Now, for the 80%, you do the same thing too. 80 over 100 times 170 you have gotten from that 220 minus 8. That is what you now operate within that heart rate. That is what is caused by that range of heart rate. That is maximum heart rate. And whatever the procedure the patient is doing, like in this instance, aerobic training, which is cycling, it will be done at the range of 70 to 80% of the maximum heart rate of the patient. It is done 3 times per week, and the good result at 12 weeks, there is no randomized control trial have shown that. There's also this combined aerobic cycling with dynamic training, resistance training for the patient. Also done at that 80% maximum heart rate for the aerobic. For the resistance training, done like 15 minutes at a 50% maximum heart rate, and that is done at 12 weeks too. Then it has been shown adverse effect. Don't forget, what this procedure is all about is to increase the blood flow. Is going to increase the musculature strength of the patient, both the musculoskeletal one. Is going to increase also the better performance of the heart musculature, as I'm going to show to you in subsequent slides. Then there's also the possibility of using treadmill for the patient. That is also shown to be effective in this instance, operating at 90% target heart rate. Also within that 12 months, it is effective. Of course, when you talk about now, they are talking for stage 1, class 2. They'll be able to benefit essentially from this. So let me log this one out now as I pick another one. Let me share another one with us. Let me share this one, which has to do with classification of aerobic exercises again. This classification is done according to ACSM. ACSM is American College of Sport Medicine. These are the kind of recommendation that is given in this instance. Let me pick this up for us. Please permit me. Okay. Now, for light exercises, the VO2 max, that's maximum oxygen consumption of that patient, will be between 37 to 45, and then the intensity will be a very low one for that patient. In this instance, the patient is operating at the level of 30 to 39% heart rate, and then the repetition is between 10 to 11. This is also good in terms of aerobic. And of course, you know, this will be beneficial to the early presentation of the patient. That is what with light intensity exercises. For the moderate one, the intensity can be between 46 to 67% working for the patient. It will be productive and there will be no adverse effect on the patient. But for the vigorous one, of course, this cannot be prescribed for the one that is on the stage 4, stage D, classification 4. This can just still go for the one that is on classification 1 on New York classification, or probably on the staging classification of the patient. Let me pick another one again for us to share with you before I move back to our slide. Let me go to contraindication. Now, still picking this again, we look at the issue of contraindication to training. It's the issue of signs of excessive strain and safety criteria for phase 2. And in those instances, we look at contraindications across conditions. Please let me pick this slide. When there is a progressive increase in heart failure symptoms, in the issue, there's excessive strain in instance of severe fatigue, dyspnea out of proportion to the level of exertion. In that instance, the patient cannot actually cope. The cardiologist will work on the patient, intervening in the management of the patient, bringing up another referral for the patient to continue intervention as the patient becomes stabilized at high level. But low moderate exercises, or like free active exercises, can be prescribed for patients in that instance. Then respiratory exercises can be adopted in that instance for the patient, but the respiratory frequency of more than 20-30 beats per minute will not be much for it, because unexpected increase in breathing rate can actually occur in that instance. And instances too where there is dyspnea while speaking. All of us know about this, what they call talk test in exercise prescription or singing test. What singing test or talk test is all about is whether a patient can still sing while walking, whether a patient can still sing while doing his activity, or whether the patient can talk while doing activity. Any activity that can be done while the patient is still speaking or doing activity can still be termed within the range of moderate one. Immediately the patient, there is cessation of talking, not that the voice has gone, but because the energy has been served that the patient is struggling to cope, in that instance the exercise is so much, the patient will not be able to go ahead in such instances. So these are the practical something illustrations I said I will give unto you. You have more of it to go through in the process of your further study and appreciating the illustrations that I've given unto us. I'm going back to our slides now as I go to slide 123 now. I want us to stretch our legs. Let's stretch our legs. Let's stretch our legs. Let's stretch our leg. We'll be back now very soon. We are welcome back. We are welcome back to class. I want to explore the the different systemic and structural advantage of our intervention, so that we know that we can have, the patient cannot afford not to do. It's just a case of moderating what to do. And the intervention that we have talked about so far under physiotherapy intervention has the following advantage. On the cardiac structure, it has the advantage of increasing the plasma volume, decreasing the cardiac afterload, it increases the diastolic filling, and it increases the left ventricular compliance, and we have increase in the left ventricle ejection fraction ratio, which has been the subject of attention and also of staging and classification of the patient. You now see that with the efficacy, with the strategic intervention of us as physiotherapists, we'll be able to moderate the cardiac structure and the function. Likewise, we'll be able to also moderate the pulmonary function of the patient, because the respiratory fatigue will decrease, the ventilatory efficiency is going to increase, the lung diffusion capacity will increase, vis-a-vis the ventilation perfusion ratio will be better off. Then for the musculation of the body, there's increased mitochondrial content, the oxygen utilization is there, and the type 1 aerobic fibers, they are improved. And that is, the patient becomes better, frailty is addressed, agility is increased, and performance in activities of daily living is increased. Then the vasculature structure of the patient and the function, they are better off, because the capitalization is improved in function, the vasodilatory function is improved, and you know, with that, the blood flow distribution will be enhanced, and the blood flow distribution will reach its destination, and that is done. The designated organ receive as required, and as they receive as required, there's better functioning of those organs, and then the patient will be better off systemically. I hope we're able to appreciate this before I move on. Are we together?
Yes, sir.
It's okay. Thank you very much. So we are still talking together. We are moving gradually forward. Now, I want to point our attention. Of course, I've explained this out. Let me not go too much into it. I go into this now. There's extensive evidence that shows that higher intensity exercise actually contribute to improvement in peak VO2 or maximum oxygen of the patient than and the moderate one. Of course, that can aid in exercises, and that is why there will be more demand in blood supply, there will be more demand in the oxygenation process, and then the heart will also perform better, and over time, there will be increase in the structural ability, and there will be the increase in the functional ability of the patient. So that's why the high intensity has better efficacy compared to the low intensity or the moderate intensity one. And of course, as a way of guarding again or explaining this better, we know that is a function of the stage of the patient. Very, very important. Now, the high intensity that is gradually introduced to the patient, it will be done in progression. And it will be done according to the tolerance of the patient. It will be done according to the past experience of the patient. And this may be optimal for the reducing of the discomfort of the patient. And as the patient gets to do this over time, he gets used to it, he begins to enjoy it, he becomes friendly to it, and the patient has the tendency of adhere to the prescription. The patient enjoy it more, and you expect that there will be more physiological outcome for that patient. Of course, this systematic review that I drew before us by Edwards et al., done sometimes last year, actually shows about talks about the exercise mode in heart failure, what it does. And it's still almost the line of what I discussed with you later on, that high intensity approach is significantly more effective than moderate intensity. And I've explained that out to us, how that is done. So the bottom line of it, that there is evidence to show for our intervention. And instances where it is recommended for the patient, The high intensity approach will produce better results than the moderate intensity or the low intensity for the patient. I'm gradually going now into the relevant outcome measures in a congestive heart failure. Of course, our vitals are very important. We monitor our vitals at the point of first examination, and it is recommended that in the process of administration of the treatment, the patient will be constantly monitored. In fact, if you are into critical care, if you are into the management of this category of patient, you monitor in between, in situ management. You monitor to begin to see whether something is changing, that even though you have goal, you have a treatment that has been outlined down for the patient, which is actually objective, is according to guideline. But the issue there is that the response still need to be monitored to determine the continuity of what you have already planned for the day for the patient. So in that instance, you continue to take the blood pressure, the pulse rate, the respiratory rate, the pulse oximeter will also be done. The Odima score will be done. The CAT score or all the other functional independent measure can be done, picking all the domains or picking part of the domain. The bulk rate of passive exertion too can be done. I want us to look at this slide. Slide 132. I try to a bit conceptualize what we are trying to do. Now let's look at this like a physio treatment summary outlook. We do history taking, which has to do with the presentation of problem. We look at the target physical activity of the patient and the patient concept belief about himself or what he's doing. We need to put it down. We assess, we ask for the activity level of the patient prior to the problem, since the problem started, and the current state of activity of the patient. Then we do status of the patient too. We want to know the trajectory of the presentation over the time. Then we'll assess the present state of the patient. Then we'll look at some details about the social life of the patient, about the environment of the patient. We'll try to look at the motivating factor for the patient, and we need to inquire from the patient to know the need, because his need is going to be factored into the treatment plan, into the rehabilitation plan. That's what makes this to be relevant to him and also to be beneficial, because what is the need of A will be different from the need of B. Of course, we go into examination. We assess the impairment, as you know, that we essentially do with function. We have tried to study the pathophysiology to gain better understanding of what has gone wrong and what has made patient to be presented the way he or she is, and to now know how we fit in as rehabilitation professionals, as physiotherapists. And in that instance, we look at the impairment that the patient is suffering from. We look at the activity limitation of the patient and vis-a-vis his or her problem that may, if when we need all this, is to influence the choice of exercises that I've talked about earlier on. Whether high intensity, moderate intensity, or low intensity, we determine that, and we look at the functional exercise capacity of the patient, because a patient cannot take so much, cannot be given so much. That's a golden rule. The patient that cannot take so much cannot be given so much. And of course, we now try to do analysis of what those things we have done, looking at the physical impairment of the patient, of course, coming to a conclusion, a physiologic conclusion. What are the conclusion we want to come into concerning the patient? It may be something like global deconditioning as a result of stage D of cardiac heart failure classification 4. I hope you understand what I'm saying. Global deconditioning, in which instance, we are talking of stage D now. Global deconditioning in a patient presented with stage D class 4 cardiac heart failure. I hope you understand what I've said. Class, are we there?
Yes, sir.
Are we together?
Yes.
Did you get that impression that I've given you, or I should repeat it, that impression?
Please repeat it.
Good.
Okay, I'm talking that like we have examined the patient now. I'm using an hypothetical case. Now, with all the things you have found out from the patient, you want to form an impression, and you just see the patient cannot do anything for himself or for herself. And you look at the trajectory of the patient, you've examined all the results, you come into the conclusion something like this. Global deconditioning in a patient presented with stage D class 4 congestive heart failure. Do we understand that?
Yes, sir.
Yes.
Okay. And you can now imagine the picture of that patient. What will be the now go into rehabilitation goals? So it goal has to do with optimizing exercise capacity. You reduce the dyspnea, the fatigue, and the inactivity of the patient. And then the general goal will be exploring the physical limit of the patient and how you can make him or her to be able to do what he's supposed to do. And that makes you to actually form what we call what is called a long-term goal and short-term goal of the patient. But I don't want you to forget the way you are going to come into that impression. That impression you are coming to for that patient, which we call physiotherapy diagnosis of the condition of the patient, is flow out from the presentation of the patient and also the functional assessment tool that you have used for the patient. I won't go too much into this again, but just to remind you about the risk factors of the patient, about the functional assessment, and that is of interest to you as physiotherapists, which I've explained to you. Where my cursor here is about the New Yorker classification 1, 2, 3, 4, and then of course we should easily be able to do the classification now. And then the ACA-AHA1, which has to do with the staging of it, and then new admission with congestive heart failure. There's need to look for signs and symptoms. You know, we are talking about admission and readmission cycles. You look for signs and symptoms that is fresh in that patient, not the old one. Then you look at the latest diagnostic test result. Very, very important, because that's going to determine some decision that you are going to make informing the treatment protocol to the patient, and you document your findings. Of course, what of the thing is expected is pulmonary findings in stage D. I hope you appreciate this that I'm saying. Pulmonary findings will be in stage D, because inspiratory crackles will be seen, because the lung tube will not be able to function maximally. There will be coughing, and there is a tendency for associated pulmonary effusion in that instance. Two conditions are coming in together at the same time. So we go into prognosis now of the patient. What do we expect in the management of this patient? We've talked about the admission, readmission cycle. According to the CDC in America, that's our Center for Disease Control and Prevention, something done sometimes in December 2025, December 2015, said the rate of heart failure related deaths, it decreased from 103.1 deaths per 100,000 population in 2000 to 89.5 in 2009. But along the line again, it increased again to 96.9 in 2014, where we will see that though it has picked up again, it's still reduced compared to that. That talks about care of improved care in management. And of course, maybe aging factor coming in now, make it to further increase there. So there is prospect in the management of the patient, even though the issue of death is still there, but in about 103.1 for 100,000. Now, the report actually noted that the trend correlates with a shift from coronary heart disease as the underlying disease over in their climb to the metabolic disease. You know, we were able to explore the risk factors. We were able to explore what causes this condition. They were able to isolate there that there is a shift from coronary heart disease as a precursor to metabolic disease as a precursor to it. Things like obesity, diabetes, malignancy, chronic pulmonary disease. And if you now look at this shift now, you now see that in all of these conditions, we as physiotherapists, we have a way of coming in that will also further be able to help the patient. Now, the mortality rate following hospitalization for heart failure has been estimated to be around 10% at 30 days. 22% at 1 year, and 42% at 5 years. That is the likelihood of mortality in this condition. Let me repeat it again. It is estimated at 10% at 30 days, 22% at 1 year, 42% at 5 years. And this actually can increase to greater than 50% for patients with stage D. I know you will appreciate that. Why do you think it will increase for patients with stage D? Question.
Immobility and deconditioning.
Because of what?
Associated immobility and deconditioning. It will lead to buildup of many what do they call
And
those
the
things?
continuous deterioration of the patient.
Yes, infection, ulcers.
Yes, and tendency for further comorbidity, isn't it?
Yes, sir.
So it's not only a
Comorbidity.
condition
Yes.
that is managed now, many conditions will be managed. I hope we appreciate that.
Yes, sir.
It's okay. We move on. Now, we further talk about the issue of prognosis and congestive heart failure. There's what is called Ottawa Heart Score Risk Score. And this particular Ottawa Heart Failure Risk Score is actually a useful tool for determining the prognosis in patients who present to the emergency department with heart failure. The score in this case is used to determine the 14-day mortality risk, hospital admission, coronary heart syndrome, and it will help to actually arrive at safe planning for that particular patient. A score of 1 to 2 is considered moderate risk. 3 to 4 is considered high risk. A score of 5 or higher is considered a very high risk for the patient. And 1 point is given. How is the scoring done? This is the way the scoring is done. 1 point is given for each of these following. When there is history of stroke or TIA, transient ischemic attack, is 1 point. Oxygen saturation less than 90%, it is 1 point. Heart rate that is greater than 110 beat per minute on the 3-month walk test, it is 1 point. Acute ischemic ECG changes, it is 1 point. Then the following, now there are some other domains that pick 2 points each. History of prior history of mechanical ventilation will pick 2 points. Heart rate greater than 110 beat per minute again will pick 2 points. This is the way the scoring is done. And by the time all this scoring is done for the patient, if the patient has 1 to 2, the patient is moderate score. If the patient has 3 to 4, after doing all this scoring, whether 1 point scoring or 2 point scoring, the patient is high risk. And when the patient has a score of 5 or higher than that, the patient have very high risk. This has to do with Ottawa heart failure risk score. I hope we appreciate this, Ottawa high risk score. I hope we appreciate this Ottawa high risk score. This stems from observation, presentation, the data that you took from the patient, the laboratory results. I hope it is understood.
Yes, sir.
It's okay. Thank you. So you can now know who is at risk or who is not at risk. The risk categorization, once again, is low risk, moderate risk, high risk. We continue to move further. I want to look at case presentation now. I promised us earlier on when we started this workshop that we're going to do some practical teaching in the illustration, by way of illustration for a patient. We look at this, a patient, a male patient, 21-year-old, who presented with chest, a summary of presentation, chest pain, inability to ambulate, inability to urinate, breathlessness, bilateral pedal edema, palpitation. This is the history of the patient. The first admission was on account of chest pain and unwellness. In fact, as at that time, this patient were thinking it's ascites that the patient had another admission, the second one where he was kept for observation for another 1 week. Then 2 months post-discharge, this patient started feeling unwell again with breathlessness, easy fatigability, and deep vein thrombosis was there and blood vomits. Then another admission, which happened to be the third one in this instance, for another 12 weeks was done. And the patient was placed on antibiotics, clexane, furosemide, among others. Then another admission, the fourth one, was done within 1 week post-discharge of the third one. This was for 2 weeks. You can see there now, this correlates with the circle I told you of. Admission, readmission for the patient. Then we move on. As part of the history of presenting complaint, the patient just spent 3 weeks at home again before the latest admission of the patient, which happened to be the fifth one. Then the patient was placed on supplemental oxygen 3 days after admission. And the patient was treatment included clexane, rosfin, furosemide, warfarin. Hematologist too, as part of the team managing, they gave him some consultation. Now, DVT was detected 2 weeks post this fifth admission. and his movement was actually subsequently restricted, and the patient was placed on 2.5 milligram warfarin. The breathlessness actually improved. The patient was weaned off supplemental oxygen. The patient now begins to eat well. The patient sleeps now and is able to urinate, and the patient now has started ablating, but still have breathlessness and rest, relieved by forward leaning in sitting position. The social history is that the patient is third born of 6 siblings, 2 male, 3 girls, 2 girls, 4 boys. The immediate brother of this patient died of the same condition 5 years prior to presentation. This is the observation that was done for the patient. The patient was actually look frail looking, and then the blood pressure was 120/80, the pulse rate was 101, pulse score was 4 plus, and there was no jugular venous distension. The respiratory rate was 24. The SpO2 room here now, don't forget that we said that the patient has been one of supplemental oxygen is now 96%, with bilateral chest symmetry, and the ear entry for the apical lobe was fair, so the basal lobe was reduced, the chest was clear with there was no swelling on the chest, then the shoulder was rounded with increased AP diameter, and there was reduced thoracic excursion for the patient. The cough that was presented was unproductive. Then there was first degree finger clubbing for the patient. The range of motion, whether passive or active, was full and pain-free for the patient in all the joints of the limb and also the cervical joint. And the gross muscle power is 3 plus. And then for the integumentary, there was bilateral pedal edema 4 plus. And then there was no hand edema anyway. And then the patient has some exaggerated stretch mark in the lower thoracic. Now, these are the classification that I put beside here now. What do you think will be the classification of this patient? I'll leave you 5 minutes to think and begin to answer it in the chat box for the next 5 minutes. Then we'll continue. Answer in the chat box. Put your answer in the chat box.
Agent class again, dummy.
I'm giving you further slides that will guide you further in your answer. Further slides that will guide you further in your answer. I'll flip these 2, 3 more slides for you. I hope you have seen the slides that I'm flying to you. I hope you are reading the slides that will guide you in your answer. Are you hearing me?
Yes, sir.
Okay. I hope this will guide you in your answer. In the next 2 minutes, we'll round up your questioning, answer to your question. Ooh. Okay, I'm going to do something now. I'm going to it will guide you in your answer. You see the slides I've shown? Are you seeing my slides?
Yes, sir.
Okay. You can still change your mind and write another one. Oh. Fine, 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 fine. You are welcome back, class. You are welcome back, class. Are we together?
Yes.
So what is the answer?
Stage C, class 4.
What is the answer?
Stage C, class 4.
Stage C, class 4.
Stage what?
Stage C, class 4.
What makes it stage C and not stage G? What makes it stage C and not stage G? Take into consideration all this.
Oh, it's stage. It's stage D, class.
It's okay. Thank you very much. This is summary of the sliding of the page. D4 is D4, D4. Because you see, there's a lot of abnormalities, structural abnormalities now that have started taking place with comorbidity presentation. I hope you notice this. Can you see it?
Yes, sir. Yes, sir. Yes, sir. We can see a lot of comorbidities.
That's actually the bottom line. If you say C will have been correct, but if you look into take into consideration the further structural abnormality that has been taking place, you will see that the patient has advanced in this condition. So I move on. So this is a summary of it. The patient has breathlessness, easy fatigability, reduced respiratory effort, labor breathing, chest pain, inability to ambulate unaided, reduced activity of daily living, breather pedal edema. I hope this is consistent with what I've taught earlier on concerning the presentation of the patient.
Yes, sir. Yes,
is it consistent with it?
Yes, sir.
It's okay. Fine. Now, these are the first for a short-term goal for the patient. Maintain airway potency, ensure minimal activities of daily living within patient's tolerance. Why do you think that has to be? Why do you think that has to be?
Because you cannot carry out any ADL.
Because we noted in the examination that the patient is still having breathlessness at rest, isn't it? I hope you remember.
Yes, sir.
Yes, sir.
Oh, okay. Now note what one of the things said. Look at where this my cursor is now. One of the things said as part of the short-term goal is close monitoring on patients' vital pre and in between and post-treatment administration. I hope you can appreciate the reason why that has to be.
Severe case, yes, sir.
Thank you. Now, the short-term treatment tests are pulse sleep breathing, free active exercises, CMAS ambulatory retraining, exclusively under the physiotherapy intervention. Base technique, TED socks, therapeutic positioning. Then from there, we launch into the long-term treatment goals. We continue to maintain the patency of the airway. Don't forget, I told you some portion of the lung field has reduced air entry. That is the lower lung field. The apical lung field has a fair air entry. So we still continue to attend to the lung. Then we continue to work within the tolerance of the patient. We continue to manage the breathlessness, and then we'll begin to do guided ambulation under serious supervision of the physiotherapist. Then we'll manage possible exacerbation because of the stage the patient is. If there's any exacerbation, you factor it into the long-term planning and you also manage it. Then you ensure the patient daily and moment-by-moment safety. In between treatment, you are there really daily. You may have to pass some instruction while you are there, what the caregiver need to do, and how you also get a response back from the caregiver. That means the caregiver has to be part of the patient education scenario that has to be created by the patient in the management, and also the moment-by-moment safety of the patient. Of course, the psychosocial support is very, very important for the patient. Then these are the treatment protocol that will be adopted. Of note here is this fourth one. We discourage prolonged immobility. Don't forget, we have been able to successfully demonstrate through evidence-based approach the necessity of intervention. It's only that the intervention will be graded along the line based on the stage and based on the classification. But we want to discourage immobility. So in the long-term goal, you discourage prolonged immobility, except when absolutely impossible. I want us to take note of that. So we continue to use our pacing technique for the patient, and you begin to adapt the patient to the living and the working environment of the patient. Going back to the question earlier on asked by one of the participants in this workshop, this course, when I was doing the protocol packaging based on this classification of New York, we talk about the maximum of 7 metabolic equivalent of times. We talk about it being less than 2 in stage 3 of it and class 4. So we'll take all those things into consideration to adapt the patient to his and living and working environment. The possible prognosis of this patient is that the patient will be able to achieve some level of functional independence with consistent physiotherapy. The physiotherapy has to be consistent, just that we sequence the intensity of intervention, and then with physiotherapy intervention, medical follow-up, and psychosocial support. This is another case report. In this case report, it has to do, this one is still not far off. It's something done still within the last few years. It has to do with the one I showed to you earlier on. You know, I told you CHF can occur at any age, even though at like age 50, the percentage increase a bit, and then like greater than 65 or 75, the percentage also increased to about 7% or 10% thereabout. So the first one I presented was a male, 21. The next one now is 51-year-old female. And the patient at the point of examination, these are the brief summary you can put for your patient. The patient at the point of examination was on class 3 of New York without any musculoskeletal pulmonary comorbidities. I hope you appreciate that now when you compare it with the other man or the other person I presented. This one is without musculoskeletal or pulmonary comorbidity. Then, seeing it all, this patient, they're actually trying to look at the efficacy of continuous positive airway pressure on the cardiac rehabilitation with congestive heart failure. When you combine it with, when you combine exercise protocol with continuous airway, positive airway pressure, what does it going to have more effect than just using exercise alone? And then the issue of continuous positive airway pressure as an adjunct therapy has been shown in several studies, notably this study in 2000 and 2006, the one by Sin and the one by Whitman, that it improves cardiac and pulmonary function with relief of symptoms in patients. So they actually have a basis to get that done. And the protocol was packaged in such a way that it's 4 weekly sessions for a period of 6 weeks. 4-week session for a period of 6 weeks, and it continues positive airway pressure. And the effect that it has brought is shown in this diagram. I'm bringing before you in slide 152. The 6-minute walk test, which was 150 to 520 post this intervention, that's a post 6 weeks. Then the Minnesota questionnaire on quality of life network. We are back now. I hope you are hearing me. Are we hearing me?
Yes, I can hear you.
Okay, now this procedure that I told you is combining the continuous positive airway pressure with exercise for a period of 6 weeks. Now it shows significant improvement in these indices in this patient. That's to show to you that as intervention is a evidence-based intervention that can easily be reported out. The 6-minute walk test, the distance covered at the point of this assessment of this 51-year-old woman in New York classification 3 was 152.5.
Your network, we can't hear
to
you.
520. On Minnesota 2, there's okay. Let me stop now. Are you hearing me now?
Yes, we can hear you now, sir.
It's okay. You remember that the New York classification of this patient from the assessment was 3. It dropped to 2. Is that an improvement? Is that an improvement?
Yes, sir. That's an improvement.
Yes. Then look at the ejection fraction ratio. It's increased from 33 to 36. Is that an improvement?
Yes, sir.
Yes, sir. An improvement, sir. Your network again is gone.
Yes, isn't it? I'll show you how ejection fraction whether are you hearing me now?
Yes, sir.
Yes, sir. Yes. We can't hear you again now.
Are you hearing me now?
Yes, sir. We can hear you now.
Okay.
The network is
now I'm trying to us indices of improvement in this. Okay, let's wait for it. Are we there?
Your network is shaking.
Are we hearing me now? Okay, still shaking. Okay.
We can hear you now.
Now we can hear you now.
Everybody hearing me now?
We can hear you. Yes, sir.
So it's okay. I was trying to show the effect of this continuous positive airway pressure, one of our interventions combined with exercise in the management of this patient. You know, several studies have been done singly, each of them, but combining them together like this adjunct therapy in addition to other treatment. It's not that this treatment will stop the other intervention. Intervention and the like. So when those things are parameters increase, no, this means to explain to you this ejection fraction. It's increasing this study.
Your network.
Even though that study was considering now is 4 weeks. Now, I'm hearing you. Are you hearing me?
We didn't hear what you said, though. Yeah, we can hear you now. We can hear you now.
It's okay. I was trying to discuss the efficacy of our intervention as elucidated by this particular report.
All right.
Improvement in 6-minute walk test, improvement in injection fraction ratio, improvement in the New York Heart classification. Did you hear that?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Okay, but I was trying to actually combine two studies now. The one we are considering is for 4 weeks, which has improvement of 33 to 36% EF, ejection fraction. But another one has been done, but that one is for a longer period, 6 weeks. Its own improvement is 30 to 35% ejection fraction. I hope we had that.
Yes, sir.
Yes, sir.
But I'm still trying to now compare this with what I've taught you before, that
Yes,
even
sir.
with this improvement, can't
It's
you
not
see
a
that this is still below 40%? So
yes, sir.
when
It
you
does
are
not change the
categorizing, it's
class.
still
Yes, sir. It's below 40%.
reduce ejection fraction ratio. Isn't it true?
True, sir.
Yes,
It's
sir.
true, sir.
Yes, sir. Does not change the class.
It's true.
Okay, fine. Just for illustration for you to see now, network. Can you hear me now?
Yes, sir.
Yes, sir.
Yes, sir.
Hear me now?
Your network
Okay.
is
One of the indices consumption by the myocardium, oxygen consumption by the myocardium. I'm going to take some little minutes, probably some 5-7 minutes, to explain what that stands for. At this point, to go into that and explain that this maximum, this oxygen consumption by the myocardium is, you see it as written as MVO2. I is obtained in systolic blood pressure times heart rate. So was also improvement in that. So that brings me to that cardiac oxygen demand, which you need to know. The cardiac oxygen demand is actually
Your network is seriously affecting the flow. You cannot even get
determined by
anything
the
you're
amount
saying.
of work done by the heart. The latter stroke, I told them. Are you hearing me now?
Yes, we are not getting the explanation for the clinical significance of cardiac oxygen demand. We are not getting it.
Okay,
The
let me
network
go back
is breaking
here. Clinical significance of cardiac oxygen demand. Now, I told us how we are going to obtain it. It's a function of the systolic blood pressure times heart rate. Did we get that?
Sir, yes, sir, we get that. Yes, sir.
Okay, now I'm not delving into the clinical significance of it. The cardiac oxygen demand is determined by the amount of work that is performed by the beating of the heart, which is a function of the coronary blood.
Breaking up again, sir.
Now, it is possible cardiac oxygen demand in the latter stages of coronary artery disease. Did we get that?
No, sir, we are not getting it at all.
Hello?
The network is disrupting the flow. We didn't get that, sir. We only get when you said the what is it called? Systolic times the heart rate.
There is need to change the network.
I'm hearing you, but you're not hearing me. Let's wait a bit. I told you that MVO2, are you hearing me? Man, is gotten by multiplying the heart rate with the systolic blood pressure. You're not hearing again? Hello?
We can hear you now, sir. We can hear you now.
Can I go on?
Yes, sir.
Yes, sir.
It's okay. I was trying to explain to you. Did you get what I what I said about cardiac oxygen demand, how is it determined? How is it determined?
It says systolic blood pressure times the heart rate.
Network is really disturbing the flow.
I said by the amount of work performed. Are you hearing me now? Are you
Yes,
hearing me
sir.
now?
Yes,
Sorry,
sir.
network locked me out.
The network is still disturbing, sir.
I'm going to reshare my slide now. Are you seeing my slide?
Yes, sir.
Not yet, sir. Not yet. Okay, yeah, he's back now.
Yes, we can see your slide now.
The network is really disturbing. We
Hear
can
my
see your
voice?
slide.
But what of my voice? Can you hear my voice?
Just came up now, but it's breaking.
Okay. Okay. Let me call for a break in the class for 15 minutes. Let me call for a break.
All right. All right, sir.
Okay. Let's come back at 2:30 Nigerian time. Is that okay?
All right.
All right,
Yes,
sir.
sir.
Welcome back to class. Welcome back to class. Are we together? Welcome back to class.
Yes, sir.
Well, welcome back to class.
Thank you.
Yes. How was your break?
Bye.
Fine, sir.
So we are welcome back. Let me pick up from where I stopped the other time. I've explained to us how the cardiac oxygen demand can be computed. I've told us that it's a function of the systolic blood pressure and the heart rate. And I'm just trying now to explain the clinical significance of cardiac oxygen demand. I did tell us that it actually is primarily determined by the amount of work that is done by the heart per unit time, which is a function of the coronary blood flow. And I also told us that there is a possibility of rise in myocardial oxygen demand over years as a result of poorly controlled hyperlipidemia due to coronary artery disease, in which instance the inner layer of the vessel will become laid with plaques, gradually reducing the diameter of the vessel, reducing the amount of blood that passes through the major artery. That is what can lead to rise in oxygen demand. Now, this pictorial that I've given here now in slide 154 talk about the oxygen demand and the oxygen supply. The oxygen demand is determined by the wall on the wall stress, by the heart rate, by the contractility of the muscle. Now, the supply is determined by the flow, the coronary flow, which I just finished explaining to us. So we have two sides of it, the demand, the supply. The demand, that's the myocardial volume oxygen supply or demand, is determined, the demand is determined by the wall strength, the heart rate, and contractility. Of course, from the pathophysiology that we have explained over time, you should be able to understand the reason why the oxygen demand is determined like that. Now, the supply is determined by the flow. How easy is it able to pass through the vessel? That explains the myocardial volume oxygen demand and supply. Now, when there is a fluctuation in it results in some issues which you can see in patients. Now, patients that are having atherosclerotic CAD, coronary artery disease, they develop problems like what is called angina pectoris, myocardial infarction, or sudden death. And this is as a result of this situation whereby the myocardial oxygen required by the activity exceeds the oxygen that is supplied. So there is a struggle. What is required exceeds what is supplied. So there's angina pectoris, there's myocardial infarction, and the possibility of a sudden death. Now, the same myocardial oxygen demand that I'm talking about, the consumption of it is determined by the preload and afterload that I talked about earlier on, the contractility, the heart rate. Now, the myocardial oxygen consumption itself, it can be increased by the dilatation of the left ventricle when the lumen is widening enough to allow the blood to flow, which happen in cases to explain this myocardial oxygen consumption to us, because it's something very fundamental to us, which I want us to get. It is a measure of the work performed by the heart. That is the summary of what I'm passing across to us. Myocardial oxygen demand is a function, is a measure of the amount of the work that is performed by the heart per unit time, and is determined by the coronary blood flow. I hope we are able to get that.
Yes, sir.
It's okay. Thank you. Let me move on. Now, as I continue with the clinical significance of the cardiac oxygen demand, now when the heart rate is increasing, we will expect that the myocardial will have to work harder. I hope you understand what I'm saying. When the heart rate is beating bam, 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 very fast, what do you expect will happen to the myocardium, the muscle? What do you expect that will happen? It will work harder.
Fatigue.
more cardiac to be able to complete the cardiac cycle more efficiently, isn't it? Do we agree on that? Did you understand that?
Yes, sir.
Okay, now, so I'm trying to still further elucidate on a clinical significance of the cardiac oxygen demand. But in ordinary normal condition, the oxygen demand is supposed to be equal to supply. In that instance, you don't have any challenge. The challenge is when the demand is not measuring with the supply. Then there is going to be challenge. Like the one I quickly explained to us here now. In the case of angina pectoris, myocardial infarction, and sudden death, what happens is that the required exceeds what is supplied, and there is now a struggle. That's why you have those presentations in there. But the ideal scenario is for the supply to be balanced with the required. But when the supply cannot balance the required, of course, you know that what is needed by the structure is not gotten. And that's why you see conditions like angina pectoris, arrhythmia, myocardial infarction, and possible sudden death. Of course, there is a lot of compensatory mechanism that can come up as a result of this. Compensatory mechanism, the intention of it is to ensure that the cardiac output is brought to normal level as a result of the challenge in the supply and the demand of the cardiac myocardial oxygen demand. Now, but this mechanism to increase the output will later on get to a level in which it will damage the pipe. Let me go to the analogy I gave at the beginning of this lecture, that when you have a pipe, let's not use the galvanic pipe, metal pipe. Let's use the plastic pipe. Let it not even be as good as the conventional plastic pipe that you know. Let it see that it's just made up of just pipe, plastic, something. You know, when the pressure is on that pipe, what do you expect that happen to that pipe over time? When the pressure is so much, struggling to beat up with the water from the water corporation, what will happen to the pipe? What do you expect will happen to the pipe?
Tear, it will be having some linear tear.
Linear stress, isn't it? Then there will be structural damage with it, isn't it?
Yes, structural damage.
Then no matter the compensatory mechanism, do you think it will perpetually be able to cope?
No.
Because already it's been destroyed structurally. Isn't it?
It is.
Okay. So that is the situation that you have here. It gets to a level that the compensatory mechanism will not be able to work significantly to cushion the effect of that reduction. So I've taken time to explain to us the clinical significance of cardiac oxygen demand vis-a-vis the supply. Let me also explain the clinical significance of the continuous positive airway pressure, CPAP, to us. That is also very important, because what it does is significance is that once that is administered, the interthoracic pressure is increased. And once the vehicle preload and afterload, and when there's a decrease in the left ventricle preload and afterload network, are we together now?
Yes, sir.
Yes, sir.
Okay, now.
It's
Clinical
fluctuating again,
significance
sir. We
of
can't hear
continuous
you.
positive airway pressure.
The network is really dealing with the lecture.
Are you hearing me now?
Oh, yes, sir.
Yes, sir.
Can I continue now?
Yes, sir.
It's okay. I'm trying to explain to you the clinical significance of continuous positive airway pressure. What happens is that there's increase in interthoracic pressure with reduction in the left ventricle preload and afterload. All this lead to increase in the stroke volume and the outflow volume. And that's why you see it in that in that case report I was given earlier on the 55-year-old female woman presented with class 3 New York classification. That's why you see that in that particular procedure, there was an improvement because of the protocol that was administered. I hope it's understood now. Can we understand the reason now where CPAP can lead to positive change in management of our congestive heart failure?
No.
No, sir.
Please listen very well. Let me go it once more.
Your explanation.
You are not hearing me?
The network, along when you are explaining, the network is altering your voice. And it's making us to miss out.
You hearing me now?
Yes, sir.
Now, what's the clinical significance of continuous positive airway pressure? It leads to increase in interthoracic pressure. What did you say?
Somebody is
Please reduce your volume.
Mute yourself. Mute yourself. Okay, there's increase in intrathoracic pressure with reduction in the left ventricle preload and afterload. All this leads to increase in the stroke volume and outflow volume. It is as a result of this that you see it having some positive change in the management of that woman with 55-year-old presentation of cardiac heart failure. Do you get it now?
Yes, sir. We understand now.
Okay.
Yes, sir.
Thank you. Now, one of the protocol that can also be that is being shown now with evidence, even though more work will still need to be done, as part of our physiotherapy protocol in the management of this condition is hydrotherapy. It's hydrotherapy. Now, this hydrotherapy has been shown to improve cardiac function because it increases the early diastolic filling and the heart rate, which of course also lead to the improvement in stroke volume and the ejection fraction ratio of the patient. I want us to take note of it. It's a protocol that can be administered. It's evolving. I know many settings are beginning to add it, but it's been shown to be effective in some instances. Again, it's been shown in a 51-year-old male presented with cardiac heart failure with about 40% left ejection fraction ratio figure. And the intention of it is that it has positive effects on the system of the body in such a way that the cardiac function will improve because the diastolic filling is going to improve, particularly the early diastolic filling. The heart rate too will going to be stabilized over time, leading to an increase in the stroke volume and the ejection fraction ratio of that particular individual. And that's why it's also be an evolving and emerging protocol in the management of the patient. I want us to take note of it because over years we'll see it showing up more, and as more establishment also come up with this kind of infrastructure to manage patients. In the scenario that is shown up here, the quality of life of the patient actually has changes in it. The body mass index of the patient too has changes in it. Likewise, the systolic blood pressure of the patient too has some positive change in it. The hip circumference of the patient actually was unchanged by ordinary regular training. But as a result of hydrotherapy intervention, there is 4 centimeter decrease in the hip circumference of the patient. When you look at all these parameters that is taken into consideration in the management of this 51-year-old man, you begin to see the emerging role of hydrotherapy in the management of this condition. A lot will still need to be done about it. But we should take note of that, and then more specialized attention will be done. I have a lot of slides that you're going to look at over time. I'm not playing with you because we have of our time management, but let me play one for you.
There is no volume there. We can't hear the sound. The sound is missing.
The volume is not coming through, sir.
Fine. Thank you. I hope you are able to get that. Let me.
No, sir. We didn't hear anything from the video. Just the video. The sound was not there.
Something wild.
Yeah, the sound is missing. Oh, the sound is missing. We can't get anything from the people speaking. Sound is missing in the video.
Okay. Are we together? Are we together?
We could not hear any of the videos, sir. I think it might be better if we move past the videos and read it later because the sound is not
What
coming
happened to
through at all.
you? What happened? Why did you not hear it? I increased the volume.
It was not. It's from
I
your
think
end,
it is
sir.
only playing. It is probably only playing on your side, sir, but it is not coming
Yes.
through to
It's not
us.
coming through to us. Yes. It's not coming through to us.
Okay, I'm coming. I'm coming. I'm coming. I want you to actually listen to some of them. Let me Let me go back. You tell me whether you are hearing or not. Are you hearing this one?
No.
Sir.
No,
No,
sir.
sir. No, sir.
I think it is playing on your microphone, sir, but it is not. Can you
On
hear
the
us, sir?
on the speaker.
Okay, I'm hearing you.
I think it
It's
is
okay.
just playing
Okay.
on your, maybe when it is playing on your speaker, your microphone mute or something, but we're not hearing it. So it is only playing for you. It is not playing for us. It's not sharing the sound to us in any way.
It's okay. It's okay. I think there's I think let me try once again. If it's not, I will. Are you hearing this one?
No, sir. No, sir.
It's okay.
No, sir.
It's okay. Okay, no problem. Let me just stop it. Let's go on. When you get it, you get some serious illustration from them. Thank you. We move on.
All right, sir.
Now, we begin to round up. There's actually a lot of videos, practical illustrations that are going to have very self-explanatory detail. That's why number of them is already there. It's unfortunate that I couldn't play to your side there. But never mind, it's something you'll be able to pick easily. That further buttress practically all what we have discussed today is not different from what we have discussed today, but that show to you the practical dimension to it in a way that you will be able to view it, you'll be able to visualize, you will see that this is what I have been taught in the class today. As we conclude today, I want us to take note that heart failure is a chronic and progressive condition. Of course, you can pick that from what I have said today. And it is actually stems from the deficiency in the ability to maintain efficient pumping work of the heart to the extremities, to the organs, and to the skin. And that's why you now see a lot of complex symptoms being developed in the patient. Now, there's a lot of hemodynamic, neuroendocrine, inflammatory, autonomic, pathophysiological, compensatory mechanisms that are triggered off as a result of this congestive heart failure. Of course, it will include organs like kidney, lung, liver, skeletal muscles, and the resident organ itself, that is the heart. Are we together?
Sir.
Are we together?
Yes, sir.
Fine. Now, what eventually results is the conditioning effect. You remember the diagnosis we came into concerning one of the cases that was presented. I told you essentially what that patient was presenting was a deconditioning of the system. Now, so what eventually results from this cardiac failure is congestive heart failure is the conditioning effect on it in the systems of the body. And that's what makes you see the patient to present with different signs and symptoms, with substantial, which is of course related to us now as physiotherapists, with substantial limitations to the cardiac for the physical function of the patient, reduced quality of life, and multiple admission. That's what caused that cycle of admission, readmission of the patient. Of course, which of course will require extensive medical care, and we are making physiotherapy inevitable. So in the management of congestive heart failure, you expect in almost all instances, no matter the stage, no matter the classification, that physiotherapy will be involved in the multidisciplinary management of that patient. But the protocol will be modified based on the diagnosis that has been made for the patient, depending on the stage, depending on the classification, depending on the physiotherapy diagnosis that have now been made on the patient as a result of the presentation. Of course, this will be monitored over time with a lot of the previously used diagnostic tests, which can also be used as outcome measure to know whether the patient is improving or not. You know, I told you one of the gold index there is the ejection fraction ratio, whether it's improving or not. That changes the whole lot of things concerning the patient. Of course, the reassessment of the patient using our quality of life, index functional independent measures will show to us whether the patient is improving and whether the patient is getting more ability or not. And that will also help us to modify our intervention in the end. So as a way of recommendation, people living with predisposing factors, they need to seek early medical intervention. Very important. You know that it's been said as a way, just as the way this workshop was packaged together, that it doesn't happen in a day. There are predisposing factors to it. So if those predisposing factors are highly remedied through intervention, which of course patient and individual should present themselves to a good center for appropriate attention, and they adhere to the chemo prescription, of course, and with follow-up, you expect that people living with it will live a good and comfortable life. Of course, lifestyle modification will keep re-emphasizing it. Campaign in that respect, part of the patient education packages we have, part of the total protocol we are going to use for the patient is recommended and advanced as part of the guideline treatment option implementation in this patient. Also, the necessity of physiotherapy intervention, very important, according to the guidelines that have been discussed today, and good understanding of the condition, good understanding of the presentation, knowing each stage what it is and what is going to prescribe, what is not going to be prescribed, will go a long way in helping a patient to navigate very difficult situation like this. Of course, there will be continuous engagement in update workshop. I am sure that being in this workshop today, you are better off than what you used to be before. You know class A, you know class B, you know class C, you know class C. I hope you know class A.
Sir.
Yes, sir.
I said you know class A, you know class B, you know C, you know D. Did you hear me?
Yes, sir.
These two.
It's okay.
Yes, sir.
And you know, you also know New York. 1, 2, 3, 4, isn't it?
Yes, sir.
Yes, sir.
Okay. I want to appreciate you for being in this class, enrolling in this class. I want you to go back to reflect on what has been taught, to pick them one after the other, and to begin to use it on the field. I want you to go out and get out those outcome measures that I've shown unto you. Begin to practicalize it. Begin to come back to this lecture class in quote, thinking back on what we have discussed today, and begin to apply it. When you see a case presentation, put together all the factors concerning that patient, the diagnosis tech, the presentation and co. Now knock it into those boxes of the classification I've given unto you. That's how over time we are going to develop some skills and expertise in the management of this condition. Of course, I have several references, several places I've consulted in the process of this. I give credit to every one of them, as you see many of them listed out in this reference book. So it's question time now. Thank you.
Thank you, sir.
Yes. Question
Thank
time.
you, sir.
Yes, thank you too for listening.
Yes, sir. I just want to ask a question. A newborn with, let me say, congenital heart block.
Yes.
Maybe after like maybe a week, a newborn after a week, which of the classification, either the stage or the New York or the ACC, which one is suitable for a newborn?
Of course, the first thing is that it's congenital. I hope you appreciate that.
Yes, sir.
It's congenital. Then we can't get into that until we know the ejection fraction.
That's true. That's true. That's true.
I hope you understand that from the way I've taken you today.
Yes, sir.
It's very difficult to get into any conclusion without knowing EF.
Okay, that's true.
Yes, it's okay. Thank you.
Thank you, sir.
Yes. Please go back and practicalize it. You will notice that over time, when you see a lot of history before you test, you'll be able to now put those two tables together. Oh, this is C. This is 3. This is C3. This is C4. This is D4. I hope you understand what I'm saying.
Yes, sir. Makes a lot
Yes,
of
sir.
sense.
Yes, sir. Yes, sir.
From time
Yes.
to time, free to be asking questions. You see my contact on the material that will be given out onto you. In case you have any challenge, please let me know. I hope just like this slide shows to you. Question? You have a question?
Yes, I just want to get a clarification. You said is it on all ECG sim that will see that EF? Is it
No,
EM,
it's not ECG, it's
EF?
echo. Echo is
Echo,
different
sorry,
from
echo.
ECG. It's echo.
Echo. Echo,
When
okay.
the echo is done,
Okay.
there's always a report form, like a A4 paper. That's how the results come out from.
Yes.
Out of the thing you will see there is EF. I told you, I was explaining to you that the left side, when the paper faces you, the left side corner of the paper, about the middle 2/3, you see EF there. You will see it right there.
All right. I'll check it out on Monday.
It's one
Thank
thing
you.
you should always ask your patient. You can ask them to make a photocopy, keep the original, give you, put it in the file,
All
so
right.
that everybody will know that this is the reason why you have taken this decision concerning this patient.
Oh, that's an eye-opening. Thank you, sir.
Yes, but make sure they keep their copy. Don't collect their copy from them.
Very important.
I hope, like this slide shows, I've been able to pull you out of the level you were before in knowledge of congestive heart failure to a better level.
Yes, but the network was dragging us balabulu.
But not too much. It wasn't too much.
Thank you very much, Dr. Gumade. Doctor.
I was re-emphasizing the aspect that go back, you'll be able to lift each other, just like this infographic is showing to us.
It is.
Yes, I know. I say I expect you go back to the
Network has actually wounded us. We have missed a lot.
In fact, the network was dealing with us.
And expecting. Yes, but so thank you very much. Is there any other question before I hang off and give over to the moderator?
Yes, Dr. Gumade, Doctor, I greet you. Thank you very much for
Ogundimade.
Sorry?
Ogundimade Babati. Just say Babati.
Dr. Ogundimade, thank you very much for this wonderful presentation. It's actually an eye-opener to a lot of us, and I just hope that our people out there we also have this kind of information. There was an experience I had, I think about last week in a center where I practice. There is a team of medical doctors that came for accreditation of their department.
Your network.
Incidentally, they came to my department. I was the one taking them around. And during the discussion, they asked me the condition we manage. So among other conditions I mentioned that we also manage patients that have congestive heart failure. The doctor was a bit shocked. He didn't want to believe. In fact, he said, "Did you say you treat people with heart failure?" I say, we don't treat people with heart failure, but we manage patients with heart failure. For instance, like you rightly pointed out, a lot of them come down with problem with respiration, dyspnea, and all that. That in cases like that, we consider them and we also do our exercise prescription on how to help them. But the man didn't seem to believe what I was saying. I felt like, is it that they are not exposed to the role of physiotherapists in management of such condition? I wish I had this knowledge as I have now. Probably I would have made more point convincingly, mentioning some of these things you have mentioned during the course of this lecture. And that may also, make them understand exactly the role we play as physiotherapists in this teamwork in management of patients with this condition. So by that, I say thank you very much, and I pray that other physiotherapists will also have opportunity of getting this information. It will give us a higher level of confidence in what we do without feeling intimidated from our other professional team players.
Thank you very much, Dr. Nesiole. I appreciate you. It's good having you on the log for this workshop. Thank you, everybody that came around. Please go back home, pick this and some other material that will be made available to you. I assure you that will be done to you. They will pass it across to you. Study more. Gain artistry, because clinical practice is artistry. Once you gain it, it's going to you make it relevant on your field, and you're going to help your patient a lot. Let me hand over to the moderator to continue. Moderator, please, you have the floor. Moderator.
Thank you. Thank you, sir, for the
Thank you.
presentation. It's highly appreciated. And wishing to see you some other times again. We also thank all the participants for participating. Next month will be pediatrics. So,
Pediatrics, so.
yes, all through next week. Okay, next week, upper week will be pediatrics, but next week will be a practical for a previous workshop on orthopedics. So the practical session will be next week, 7th. But from 14th September to the end of September, we will have pediatrics, physiotherapy.
All right.
Yes.
All right.
Thank
Please,
you.
Prof, he did not serve us our lunch and breakfast. He let it go around.
Okay, eat breakfast and lunch, right? Thank you.
Thank you, everybody.
All right.
Bye-bye.
Thank you so much, sir. Thank you,
Please
sir.
put
See
on
you
your
in
video.
just.
Bye-bye. Let's greet each other virtually. Bye-bye. Thank you so much. Bye-bye. Bye-bye. Happy weekend.
Happy weekend, sir. Happy weekend.
Yes,
Yes, sir. Goodbye. Happy.
Happy weekend. Happy weekend. Enjoy your weekend.
Bye-bye.
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 All right.
Bye-bye, everybody. See you. Enjoy your weekend.
All right, sir. Yes, sir.
Yes.
Joss is calling.
I hope our two coppers will be preparing to make presentations on this. Laurentia, I can see you. I think I saw Joseph too. Prepare presentations for this. Thank you.
Good afternoon, sir.
Oh, no. How are you doing? I think I saw Joseph now. I think he has left. All right. Enjoy your weekend.
All right. You too, sir.
Enjoy your weekend. All right.
Bye.